Sights and Sounds in Ophthalmology, Volume 2, covers the diagnosis and management of retinal vascular disorders. The fundamentals of fluorescein angiography were reviewed in Volume 1, Diseases of the Macula. Volume 2 is divided into 10 sections, each on a different subject, plus a self-evaluation quiz section at the end. Before starting each section, you may wish to refer to the monograph for some introductory material on that subject. Slide 1. Acute central retinal artery occlusion. This 20-year-old black female noted sudden and total loss of vision in the right eye. In the next 24 hours, vision returned. When examined several days later, visual acuity was 20/20 in each eye, and examination was unremarkable except for a relative paracentral scotoma in the right eye. 2 weeks later, she again noted sudden and total loss of vision in the right eye, but this time vision did not return. Acuity was bare light perception right eye and 20/20 left eye. Upper left, note acute central retinal artery occlusion with white edematous retina. Major retinal vessels are partially obscured by retinal edema. Central retinal vein is partially dilated. Upper center, 8 seconds after dye injection, note first appearance of fluorescein in retinal vessels. Upper right, 10 seconds after dye injection, note laminar flow in supraronasal veins before any dye has entered supraronasal artery. Lower left, 19 seconds after injection, dye first appears in supraronasal branch artery. This vessel is being filled in retrograde fashion from the inferonasal and supraronasal retinal capillary bed. Lower center, 2 minutes after injection, note that retina supplied by supraronasal artery is still not well perfused. Lower right, artist's sketch illustrates edema of inner 2/3 of retina secondary to acute retinal artery occlusion. Comment: this patient had no evidence of other ocular or systemic disease. Hemoglobin type was AA. She was taking birth control pills at the time of the artery occlusion, but the relevance of this is not known. Slide 2. Central retinal artery occlusion 1 month later. This 20-year-old black female was illustrated in slide 1. 1 month after acute central retinal artery occlusion, vision was no light perception. Upper left, retinal edema persists, but is less marked than following acute occlusion. Upper right, note that all major retinal branch arteries are completely filled 8 seconds after dye injection. Recall that dye did not fill the supraronasal branch artery until 2 minutes after injection following acute occlusion. Lower left, 2 minutes after dye injection, note subtle staining of vascular walls due to hypoxic damage to vascular endothelium. Lower right, in histologic section from another patient, note cellular death in anterior 2/3 of the retina. The letter G is in the position formerly populated by the ganglion cell layer. Internuclear layer is also thinned. Comment: the histopathologic feature of acute central retinal artery occlusion is edema of the inner 2/3 of the retina. Edema is principally intracellular. The pathologic feature of older central retinal artery occlusion is loss of cellular and fiber layers in the anterior 2/3 of the retina, with secondary narrowing of retinal vessels. Slide 3. Ophthalmic artery occlusion. This 34-year-old white female with lumbar disc disease was operated on in the prone position under general anesthesia. When she awakened in the recovery room, she noticed that she could not see out of the left eye. She was brought to the Wilmer emergency room within 2 hours of awakening, at which time she was noted to have 20/20 right eye and bare light perception left eye. The upper left photograph, taken with the patient supine, demonstrates diffuse retinal edema at the posterior pole. Upper center, In a fluorescein study taken 3 hours after back surgery, again with the patient in the supine position, note filling of all vessels at the posterior pole. Upper right, 10 days after acute visual loss, note early disc pallor and attenuation of retinal vessels. The 3 fluorescein frames in the central row, which were taken at 9 seconds left, 12 seconds direct center, and 15 seconds right, show patchy filling of choriocapillaris and considerable mottling of pigment epithelium. Note that flow velocity in the retinal circulation is slow. Lower left, temporal to the macula, note increased background choroidal fluorescence due to pigment epithelial mottling. Lower center, pigment epithelial mottling is obvious on color photograph taken 3 months later. Also, note narrowing of retinal vessels in this photograph. Lower right, also 3 months after acute visual loss, patient has developed typical picture of old central retinal artery occlusion with pale optic disc and narrow sheathed retinal vessels. Also, note pigment epithelial mottling. Comment: the probable pathogenesis of vascular occlusion in this patient relates to the fact that she was placed in a prone position during surgery for lumbar disc disease without any precaution having been taken to protect the left eye. Presumably, pressure on the globe raised intraocular pressure above systemic arterial pressure and resulted in closure of the ophthalmic artery. We presume that the ophthalmic artery, rather than just the central retinal artery, was occluded, since the widespread pigment epithelial changes seen in this patient are not seen with central retinal artery occlusion alone, because the central retinal artery does not supply the retinal pigment epithelium. Left eye vision has remained bare light perception for 4 years. Slide 4. Central retinal artery occlusion with cilio-retinal artery sparing. This 23-year-old white female has been followed at Hopkins since age 3 for recurrent episodes of fever, skin lesions, myalgias, arthralgias, and leukocytosis. A muscle biopsy at age 3 showed changes consistent with polyarteritis nodosa. She has been treated with systemic steroids intermittently for the past 20 years. In October 1975, while taking 20 milligrams of prednisone daily, she sustained a central retinal artery occlusion in the left eye. Despite a vigorous therapeutic approach, visual acuity did not improve beyond finger counting. In February 1976, she complained of sudden loss of vision in the right eye. She was examined within several hours and found to have 20/30 vision. The visual field was limited to a central 5 degrees with a 10-degree nasal island. Upper left and upper center, note appearance of optic disc and macula 5 days after acute central retinal artery occlusion. Note marked whitening of the retina above and below the papillomacular bundle. Upper right and lower left, 9 and 10 seconds after dye injection, respectively, note filling of cilio-retinal artery and no filling of main branches of central retinal artery. Lower center, note obstruction of background choroidal fluorescence above and below papillomacular bundle due to retinal edema. Note how retinal infarction immediately below cilio-retinal artery corresponds with large cotton wool spots seen upper center. Lower right, 3 minutes after injection, note normal filling pattern of all vessels. Leakage from terminal arterioles below papillomacular bundle indicates hypoxic damage to vascular endothelium. Comment: this patient's cilio-retinal artery in the right eye has enabled her to maintain 20/30 vision in that eye despite a central retinal artery occlusion. She is taking prednisone 4 times a day and the dose of prednisone is being determined by the sedimentation rate. The diagnosis is diffuse vasculitis, possibly polyarteritis nodosa, or a variant thereof. Slide 5. Cilio-retinal artery occlusion. This 52-year-old white male noted sudden loss of vision in the right eye. Visual acuity was 2400. Upper left, note large cotton wool spot in papillomacular bundle. Photograph upper center is taken in red-free light. Upper right, note normal filling of retinal arterioles 10 seconds after dye injection. Lower left, 25 seconds after injection, note filling of all retinal vessels except for capillaries in papillomacular bundle. Lower center, 30 seconds after injection, note first appearance of dye in obstructed cilio-retinal artery. Lower right, 1 minute after injection, note complete filling of cilio-retinal artery and persistent non-filling of small capillaries in this area. Cotton wool spot obstructs background choroidal fluorescence in all fluorescein frames below. Comment: this patient had open heart surgery 1 year prior to visual loss. The cilio-retinal artery occlusion may have been caused by an embolus from a cardiac mural thrombus. No emboli were seen on fundus examination. Slide 6. Branch retinal artery occlusion. This 29-year-old white male diabetic noted sudden loss of vision right eye. Visual acuity was 20/20, but there was a dense inferior paracentral scotoma right eye. Upper left, note whitening of superior macula in distribution of supratemporal branch artery. Upper right, 90 seconds after dye injection, note non-filling of supratemporal branch artery and leakage from terminal arterioles which have sustained hypoxic damage to vascular endothelium. Non-perfusion in this area accounts for paracentral scotoma. Lower left is macula of left eye with 2200 visual acuity. This eye was treated elsewhere with xenon arc photocoagulation. Lower right, 30 minutes after dye injection, note old branch artery occlusion left eye with non-perfusion in macula. Comment: this patient's visual symptoms in the right eye can be explained entirely on the basis of supratemporal branch artery occlusion. No emboli were seen, and neurologic and cardiac evaluation failed to reveal sources of possible emboli. Non-perfusion in both eyes was on the basis of capillary closure. No treatment was recommended for the right eye. In the left eye, despite the presence of macular edema, photocoagulation treatment would only embarrass the existing retinal circulation even further and would likely result in further diminution of visual acuity. Slide 7. Multiple embolic branch retinal artery occlusions. This 42-year-old hypertensive white male had a history of myocardial infarction and stroke. He noted acute loss of vision left eye. Upper left, note cotton wool spot and superficial retinal hemorrhage above fovea. Also, note yellow plaque in inferotemporal branch artery with cotton wool spots in distribution of obstructed vessel. Upper center, note bright yellow plaque in supratemporal branch vessel. Upper right is a photograph of the same area in red-free light. Fluorescein frames lower left and lower center correspond to areas seen in color photographs upper left and upper center. Note normal perfusion throughout all retinal vessels. Arrows on fluorescein frames correspond to areas where emboli are seen on color photographs. Note only very subtle constriction of retinal arterioles at points of embolic obstruction. Fluorescein travels in the plasma fraction, and the passage of fluorescein dye molecules indicates that emboli do not completely obstruct the vessels. Red blood cells, however, do not pass emboli, thereby resulting in cotton wool spots or retinal microinfarcts secondary to branch artery occlusion. Lower right, in histologic section from another patient, arrows indicate area where nerve fiber layer, ganglion cell layer, inner plexiform layer, and inner one-third of internuclear layer have been lost as a result of arterial occlusion. Comment: bright yellow plaques obstructing retinal branch vessels were described by Hollenhorst and are sometimes referred to as Hollenhorst plaques. The ophthalmologist who finds Hollenhorst plaques in the fundus is obliged to refer the patient for complete medical and neurologic evaluation to determine the source of emboli. Slide 8. Acute hemorrhagic central retinal vein occlusion. This 52-year-old normotensive white male noted sudden loss of vision in the right eye. Visual acuity was 5/200ths. Note extensive retinal hemorrhages in the color photographs top row. In the fluorograms along the center row, which correspond to the color photographs above, note that background choroidal fluorescence is obstructed by blood in the retina. Staining of vessel walls and leakage from retinal vessels is caused by hypoxic damage to vascular endothelium. Lower left, artist's sketch shows blood in anterior two-thirds of retina, especially nerve fiber layer and inner plexiform layer. Lower center, dye is visible in iris vessels 25 seconds after injection. Lower right, note dye leakage from iris vessels 10 minutes after injection. Comment: acute hemorrhagic central retinal vein occlusion usually leads to permanent loss of central visual acuity. The major complications of central retinal vein occlusion are disc neovascularization with secondary vitreous hemorrhage and rubeosis iridis with secondary neovascular glaucoma. No treatment has been proved effective for restoring vision or preventing secondary complications in patients with central retinal vein occlusion. A clinical trial now in progress will determine the role of scatter-type argon laser photocoagulation in reducing the frequency of secondary complications of central retinal vein occlusion. The rationale of this treatment is to obliterate areas of retinal ischemia and thereby eliminate the stimulus for neovascularization of the disc and iris. Slide 9. Old central retinal vein occlusion. This 55-year-old white male noted sudden loss of vision left eye. Blood pressure was 180/80 and fasting blood sugar was 225 milligrams per cent. After 18 months, visual acuity remained 2400. Upper left, note macular hemorrhages 1 month following acute central retinal vein occlusion. Upper right, 18 months later, most hemorrhages have been reabsorbed. Green lesion in center of macula probably contains hemosiderin-laden macrophages from previous retinal hemorrhage. Lower left, angiogram 18 months after acute occlusion shows dilated capillaries and capillary closure just temporal to fovea. Lower right, 15 minutes after injection, note dye leakage from all vessels at posterior pole and cystoid macular edema. Comment: in long-standing central retinal vein occlusion, visual acuity is usually poor because of irreversible macular damage. Macula may be damaged by blood, by persistent cystoid edema, by migration of pigment from RPE into fovea, or by a combination of these processes. No treatment has been documented to be effective in this disorder. Slide 10. Papillophlebitis. Central retinal vein occlusion in younger patients often has a different fundus appearance and a distinctly different clinical course from central retinal vein occlusion in older individuals. This 33-year-old white female complained of blurred vision in the right eye for 1 week. Visual acuity was 20/20. Ocular examination was normal in both eyes except for the right fundus. Upper left, note cotton wool spots and venous congestion in the peripapillary retina. Upper center, 15 seconds after dye injection, note dilatation of capillaries on disc and venous tortuosity. Upper right, 1 minute after injection, note staining of vessel walls caused by hypoxic damage to vascular endothelium. Lower left, 30 minutes after dye injection, note considerable dye leakage into retina. Lower center photograph, taken 2 weeks later, shows marked reduction in venous tortuosity and reduction in number of cotton wool spots. Lower right, 2 months later, fundus appears normal. Visual acuity remained 20/20 and she was now asymptomatic. Comment: central retinal venous occlusion in young people has been called papillophlebitis and optic disc vasculitis. Hayrab believes that inflammation is the cause of some venous occlusions in younger patients and has recommended treatment with systemic steroids for an indefinite period of time, depending upon how visual acuity responds to the medication. Whether or not steroids are useful for papillophlebitis remains to be proved in a prospective randomized clinical trial. This patient demonstrates rapid resolution of retinal hemorrhages and edema in a young patient with papillophlebitis. Slide 11. Inferior papillary branch retinal vein occlusion. This 49-year-old hypertensive black female noted sudden loss of vision left eye. Vision right eye was light perception due to old central retinal vein occlusion and secondary neovascular glaucoma. Left eye vision was 2200. Upper left and upper center note extensive hemorrhages and cotton wool spots in distribution of inferior papillary branch vein. Venules are engorged. Upper right, photograph taken in red-free light, shows stellate pattern of hemorrhage, lipid, and edema in macula. Lower left, 15 seconds after dye injection, note collateral vessels shunting blood from inferior retina to superior retina on both nasal and temporal sides of fovea. Note that blood and edema obstruct background choroidal fluorescence. Lower center, note late staining of vessel walls caused by hypoxic damage to vascular endothelium. Lower right, in histologic section from another patient, red blood cells are seen throughout full thickness of retina, but are concentrated in anterior 2/3 of retina. Ganglion cells are almost totally absent, and number of cells in inner nuclear layer is markedly reduced. Outer nuclear layer is relatively intact. Comment: 75% of patients with branch retinal vein occlusion have systemic hypertension. Between 10 and 15% of patients with branch retinal vein occlusion have ocular hypertension or glaucoma. Systemic hypertension and glaucoma should be searched for in patients with retinal vein occlusion so that appropriate measures can be taken to reduce the risk of developing vein occlusion in the second eye. Slide 12. Macular branch retinal vein occlusion. The diagnosis of branch retinal vein occlusion is not always made as readily as in the preceding slide. This 67-year-old white male had noted gradual loss of vision in the left eye for 6 months. Visual acuity was 20/70. Upper left, note loss of foveal reflex due to early macular edema. Scattered hemorrhages and microaneurysms are seen inferonasal to fovea. Upper center, photograph of same area taken in red-free light. Upper right, 20 seconds after dye injection, note retinal non-perfusion and adjacent capillary dilatation. Lower left, 25 seconds after injection, note early leakage from dilated capillaries adjacent to area of non-perfusion. Lower center, 30 minutes after dye injection, note well-developed cystoid maculopathy, which explains visual acuity of 20/70. Lower right, artist's sketch illustrates leakage from dilated capillaries in outer nuclear layer and edema in Henle fiber layer forming cystoid pattern. Comment. Gass and Michaels reported that approximately 50% of patients with branch retinal vein occlusion have 20/50 vision or better 6 months after acute obstruction with no treatment at all. Theoretically, closing the capillaries causing macular edema by photocoagulation should improve visual acuity. However, in view of the natural history data, a clinical trial is necessary to evaluate the effect of photocoagulation for this disorder. Slide 13. Natural history of branch retinal vein occlusion. The next 3 slides illustrate natural history in a patient with branch retinal vein occlusion followed for 3 years. The patient was a 49-year-old white female with systemic hypertension who complained of blurred vision in the left eye for 6 months. Visual acuity was 20/40. Upper left, note hemorrhages in area drained by occluded superior temporal branch vein. Upper right, hemorrhages extend out towards equator. Lower left, note dilatation of capillary bed inferior to fovea. Small arrow points to occluded inferior macular branch vein unrelated to the supratemporal branch vein occlusion above. Lower right, 10 minutes after dye injection, note cystoid maculopathy secondary to inferior macular branch vein occlusion. Staining of vessel walls above is also seen. No treatment was recommended at this time. Slide 14. Natural history of branch retinal vein occlusion. This patient was illustrated in slide 13. In July 1972, upper left, acuity was 20/40. In January 1973, upper right, acuity was reduced to 2200 because of macular hemorrhage. Lower left, note dilatation and tortuosity of major veins and obstruction of background choroidal fluorescence by retinal hemorrhage. Lower right, note staining of vessel walls caused by hypoxic damage to vascular endothelium. Cystoid macular edema persists. Slide 15. Natural history and photocoagulation treatment of branch retinal vein occlusion. This patient was illustrated in slides 13 and 14. Upper left, in macular photographs from September 1973, approximately 2 years after acute venous occlusion, note marked clearing of retinal hemorrhage, but additional lipid deposition in macula. Upper center, photograph from July 1972, shows no neovascularization on disc. Upper right photograph from September 1973 shows definite disc neovascularization and early vitreous hemorrhage. Lower left, note dye leakage from disc vessels 34 seconds after injection. Scatter-type argon laser photocoagulation was applied to the superior temporal quadrant to promote regression of disc neovascularization. Lower center, note absence of disc neovascularization 1 year after treatment. A small optociliary collateral vessel is seen on the superior aspect of the disc. Lower right, there is no dye leakage from the disc 1 year following treatment. Laser photocoagulation scars are seen above disc. Visual acuity gradually improved to 20/30 as macular edema was reabsorbed. Comment: the diabetic retinopathy study demonstrated that scatter photocoagulation treatment reduces the risk of recurrent vitreous hemorrhage in patients with disc neovascularization. In branch retinal vein occlusion, large areas of retinal non-perfusion are often found in the involved quadrant of the retina. This patient demonstrates that scatter photocoagulation in the quadrant in patients with disc neovascularization secondary to branch retinal vein occlusion may have an effect similar to that seen in diabetic patients with disc neovascularization. Slide 16. Management of branch retinal vein occlusion with disc neovascularization. This 68-year-old white female complained of blurred vision in the left eye for 6 months. Visual acuity was 20/20. Upper left, note vitreous hemorrhage overlying a small patch of neovascularization on the superior aspect of the disc, and subinternal limiting membrane hemorrhage below the disc. Also, note plasma erythrocyte separation in subinternal limiting membrane hemorrhage below disc. Upper center, note extensive capillary dropout, sheathed vessels, and several areas of intraretinal microvascular abnormalities in distribution of superior temporal vein. Upper right, fluorescein study documents retinal non-perfusion in superior temporal fundus. Arrow points to dilated capillaries temporal to fovea, which are shunting blood across horizontal raphe from superior temporal fundus to inferior temporal fundus. Retinal hemorrhages obstruct background choroidal fluorescence. Lower left, note pattern of scatter argon laser photocoagulation applied to superior temporal fundus. Lower center, 2 months following photocoagulation, note complete regression of disc neovascularization. Lower right, note absence of disc neovascularization on fluorescein angiogram. Chorioretinal scars are visible above disc. Visual acuity remained 20/20. Comment: disc neovascularization represents one of the complications of branch retinal vein occlusion and may occur in up to 20% of patients with major venous occlusion. When disc neovascularization is present, one usually finds extensive capillary dropout in the area drained by the obstructed retinal vein. Scatter-type photocoagulation appears to be effective in promoting regression of disc neovascularization in such cases. Obliteration of areas of retinal hypoxia leads to reduction in retinal ischemia and presumably to reduction in neovascularization producing substance, which may be responsible for the new vessel formations. Despite the initially favorable outcome in this case, disc neovascularization may recur. Therefore, careful periodic follow-up evaluation is indicated. Slide 17. Management of branch retinal vein occlusion with macular edema. This 59-year-old hypertensive white male complained of blurred vision in the right eye for 1 year. Best corrected visual acuity was 20/70. Incipient cataracts seen on slit lamp examination precluded crystal clear fundus photographs. Upper left, note macular edema and lipid deposition superior to fovea. Upper center, 29 seconds after dye injection, dilated capillaries and microaneurysms fluoresce. Upper right, 15 minutes after injection, note cystoid macular edema. No treatment was performed at time of initial evaluation. 3 months later, lower left, fluorescein angiogram shows extensive capillary closure has developed in area of macular branch vein occlusion. At this time, focal argon laser photocoagulation was recommended. As seen lower center, multiple 100 micron spot lesions at 0.1 seconds duration and 250 milliwatts power were delivered to all areas of paramacular leakage and to areas of retinal non-perfusion as seen on the fluorescein angiogram. Lower right, note photocoagulation scar superior to fovea 6 months after treatment. Visual acuity improved from 20/70 to 20/25 and has remained 20/25 for 1 year. Comment: this slide illustrates the technique of argon laser photocoagulation treatment being used in the clinical trial for branch retinal vein occlusion now in progress at the Wilmer Institute. If visual acuity is 20/40 or worse due to macular edema 6 months after acute venous occlusion, patients are randomized into a treatment or non-treatment group. Treatment consists of argon laser photocoagulation directed towards areas of retinal non-perfusion and to capillaries which leak into the macula. Slide 18. Branch retinal vein occlusion with secondary branch retinal artery obstruction. This 61-year-old white female complained of intermittent blurred vision in the right eye for 1 year. Her referring ophthalmologist found an inferior nasal field defect and arteriosclerotic changes in the retinal vessels. Her symptoms worsened despite visual acuity of 20/20. Upper left, photograph taken in red-free light shows normal disc with cotton wool spots and retinal hemorrhages above disc. Upper center, color photograph of same area shows characteristic findings of branch vein occlusion. Large arrow points to site of venous obstruction. Small arrow points to site of arterial obstruction. Upper right, note hemorrhages and retinal non-perfusion distal to obstruction sites. In lower left photograph taken 14 seconds after dye injection, arrow points to arterial obstruction. Lower center, small arrow points to arterial obstruction and large arrow points to venous obstruction. Note mark retinal non-perfusion throughout distribution of obstructed vessels. Lower right, retinal non-perfusion persists 10 minutes after injection. Staining of vessel walls is caused by hypoxic damage to vascular endothelium. Also, note early dye leakage into retina. Comment: this patient demonstrates coexistent arterial and venous occlusions. Richard Clement, working at Moorfields Eye Hospital in London, performed serial fluorescein angiograms on patients with branch retinal vein occlusion and demonstrated progressive obliteration of arterioles passing through areas of retinal non-perfusion. It is possible that the patient illustrated in this slide may have initially had a pure venous obstruction and developed retinal artery obliteration subsequently. Since she did not have macular edema or neovascularization, no treatment was recommended. In the next section, we focus our attention on the subject of diabetic retinopathy. Slide 19. Trypsin digest preparation of normal and diabetic retina. In 1960, Kuwabara and Kogan introduced the trypsin digestion method to examine the retinal vasculature in a flat preparation. This opened an entirely new dimension to investigate retinal vascular diseases and proved especially valuable in diabetic retinopathy. Upper left is a trypsin digestion preparation of the macula in a normal 50-year-old patient. Note the specialized architecture of the retinal vascular bed with the central avascular zone. This capillary-free zone averages 500 microns in diameter. Upper right is a trypsin digestion preparation of the retina from a 42-year-old patient who has had diabetes for 18 years. Note the predilection of the intraretinal microvascular abnormalities, IRMA, and microaneurysms for the capillaries temporal to the center of the macula, connecting the superior and inferior vascular arcades. Lower left is a higher power view of the photograph upper right, showing greater details of the IRMA and microaneurysms. Note the relatively normal appearance of the retinal vascular bed elsewhere, with only an occasional microaneurysm noted. The parafoveal capillary bed is intact. Lower right is a trypsin digestion preparation from a 50-year-old patient with advanced background diabetic retinopathy. Normal capillary cellular details are noted to the right of the major vessel. Arrows indicate cluster of microaneurysms and IRMA around area of acellular capillaries. These ghost capillaries are not perfused and would appear as an area of capillary closure on a fluorescein angiogram. Slide 20. Ultrastructure of intravitreal neovascularization. These sections are from a 49-year-old patient who had diabetes for 18 years. She showed classical intravitreal proliferative retinopathy before death. On the left, a 1-micron thick section stained with toluidine blue shows intravitreal neovascularization. These vessels were located approximately 2 disc diameters superior to the disc margin. On the right is an ultra-thin section stained for electron microscopy. Note lumen L is surrounded by a continuous lining of endothelial cells E with tight junctions J. Also, note well-formed pericyte P and thickened basement membrane BM. Post-mortem autolysis changes in the perivascular glia are present. This patient, along with a larger series examined by Dr. Kimura, the electron microscopist at the Wilmer Retinal Vascular Center, confirms for the first time the presence of well-developed pericytes in intravitreal neovascularization. Dr. Kimura has also observed well-developed pericytes in the intravitreal neovascularization of retrolental fibroplasia and Eales disease. Slide 21. Classification of retinopathy and the diabetic retinopathy study. The histopathologic changes of diabetic retinopathy represent a continuous spectrum. From a clinical point of view, however, it is convenient to separate background or non-proliferative retinopathy from proliferative retinopathy. The artist diagram illustrates the basic morphologic differences between these two stages. In background retinopathy, shown left, vascular abnormalities are confined to the retina. When vascular abnormalities are on the retinal surface or in the vitreous cavity, we have reached the stage of proliferative retinopathy, shown right. Distinguishing background from proliferative retinopathy is important because of the marked difference in visual prognosis between the two stages. Background retinopathy may be asymptomatic for many years, especially in the juvenile diabetic. Proliferative retinopathy, on the other hand, presents a more serious threat to vision, even in patients with good visual acuity. New vessels proliferating along the vitreoretinal interface are somewhat adherent to the posterior hyaloid. When the vitreous detaches, these vessels may be torn and vitreous hemorrhage results. The use of light coagulation has been an intriguing, rational, but unproved form of treatment for diabetic neovascularization for a number of years. The diabetic retinopathy study was designed to evaluate the effect of both focal and scatter argon laser and xenon arc photocoagulation in patients with proliferative retinopathy. Eligibility criteria for entrance into this study, sponsored by the National Eye Institute, included visual acuity of 2100 or better in both eyes, no prior treatment by photocoagulation or pituitary ablation, age under 70 years, no incapacitating cardiac, renal, or neurologic disease, proliferative retinopathy in at least one eye with some degree of retinopathy in the other eye. Most patients, in fact, had proliferative retinopathy in both eyes. For each patient, one eye was randomly assigned to photocoagulation and the other eye assigned to no treatment. Treated eyes were randomly assigned to xenon arc or argon laser groups. After 2 years follow-up, there was a marked difference between treated and non-treated eyes which had disc neovascularization at the time of the initial examination. 16% of non-treated eyes had 5/200ths vision or worse, whereas only 6% of treated eyes had 5/200ths vision or worse. There were no differences in visual acuity between eyes treated with argon laser compared to eyes treated with xenon arc photocoagulation. Since the data concerning eyes with disc neovascularization were so convincing, the Diabetic Retinopathy Study Group recommends photocoagulation treatment for eyes with disc neovascularization unless some other consideration indicates that treatment should not be performed. Slide 22. Background retinopathy with macular edema. Let us now examine in some detail the ophthalmoscopic and angiographic features of background retinopathy. This 52-year-old black female has been diabetic for 16 years. Visual acuity had deteriorated to 20/40 in each eye over a 1-year period. Upper left, color photograph, left eye, shows scattered microaneurysms and hard exudates in macular area. Upper center, early in angiogram, capillary microaneurysms are visible as focal areas of hyperfluorescence. Note predilection for parafoveal area. Note that parafoveal capillary net is intact and that there is good capillary perfusion in parafoveal area. Upper right, 30 seconds after injection, note early dye leakage from microaneurysms. Lower left, in right macula, note early dye leakage from microaneurysms. Lower center, left eye, 4 minutes after injection, note further leakage in parafoveal area. Lower right, 10 minutes after injection, left macula shows extensive dye leakage with cystoid maculopathy. Comment: this patient demonstrates classical findings of background retinopathy with macular edema and illustrates the predilection of the parafoveal capillary bed for diabetic microvasculopathy. In addition, this sequence demonstrates the need for late photographs to show the severity of the fluorescein leakage in diabetic macular edema. Slide 23. Angiographic features of background retinopathy. To permit better resolution of the fine capillary details and microangiopathy in the previous patient's angiogram, a full-frame photograph of the fluorescein transit shown upper center in slide 22 is illustrated here. Good resolution of the perifoveal capillary perfusion pattern and microangiopathy is important in determining visual prognosis and in selecting patients for photocoagulation treatment. When photocoagulating patients with diabetic macular edema, we have found the fluorescein angiogram extremely useful as a precise guide to photocoagulation. We project a transparency of the angiogram onto a screen placed immediately behind the patient in order to facilitate extrapolation from the fluorescein landmarks to the patient's fundus during the actual photocoagulation treatment session. When treating lesions this close to the center of the fovea, the smallest amount of energy necessary to achieve obliteration of the microaneurysms and other microvascular abnormalities is desired. It is important to note that it is not necessary to photocoagulate all visible microaneurysms and microvascular abnormalities, only those which cause dye leakage into the central macular region. Other microaneurysms may disappear spontaneously without ever being responsible for macular edema or visual symptoms. Arrow points to microaneurysms below inferior macular arcade, which do not contribute to macular edema and thus require no treatment. Slide 24. Progression of background retinopathy. Serial color and fluorescein fundus photography enables the ophthalmologist to document changes in fundus pathology. This 39-year-old white female has had diabetes for 12 years. 2 years ago, visual acuity was 20/20 in each eye, and only scattered microaneurysms and hard exudates were seen. Photographs above were taken in July 1974, and photographs below in July 1976. Upper left notes scattered microaneurysms and occasional hard exudates in macula. Recall that exudates are found in outer plexiform layer just posterior to leaking capillaries in inner nuclear layer. Upper center, 21 seconds after dye injection, note hyperfluorescence of microaneurysms. Upper right, 20 minutes after injection, note dye leakage into retina, but absence of cystoid pattern. 2 years later, this patient complained of metamorphopsia in the right eye. Visual acuity was now 20/25. Lower left, note increase in lipid deposition and in number of microaneurysms and dot hemorrhages in macula. Lower center, 12 seconds after dye injection, note hyperfluorescence of microaneurysms and intraretinal microvascular abnormalities, particularly along superotemporal branch vessels, corresponding to area inside lipid ring seen on color photograph. Lower right, 20 minutes after injection, note cystoid maculopathy. Comment: this patient initially demonstrated asymptomatic background retinopathy. 1 year later, progression of microangiopathy and development of cystoid macular edema had led to reduced visual acuity. We have followed many other patients with background retinopathy for a number of years without any change in retinopathy and with no visual loss. Slide 25. Diabetic macular edema in the aphakic patient. This 68-year-old white female with diabetes had an uneventful cataract extraction right eye 1 year ago. Visual acuity was counting fingers before surgery and 20/40 2 months after surgery. Upper left, note hard exudates and dot hemorrhages in macula. Arrow points to hemorrhage in center of fovea. Upper center, in histologic section from another patient, note hard exudates in outer plexiform layer with VVG stain. Upper right, 22 seconds after dye injection, note hyperfluorescence of microaneurysms and areas of capillary closure supraronasal to capillary-free zone. Lower left, 1 minute after injection, note beginning leakage from microaneurysms and intraretinal microvascular abnormalities. Cystoid pattern is not seen in this 1 minute photograph. Lower center, 5 minutes after injection, note further dye leakage at posterior pole, now developing early cystoid pattern. Lower right, 30 minutes after dye injection, note additional dye leakage and well-developed cystoid macular edema. Comment: in some instances, it may be difficult to distinguish Irvine gas syndrome from diabetic macular edema in the aphakic patient with diabetes. The macular lipid seen in this patient rarely, if ever, is seen in Irvine gas syndrome. This patient also illustrates the importance of late photographs to demonstrate cystoid macular edema. Because macular edema had reduced visual acuity and because clearly identifiable leakage sites were seen on angiography, she was a candidate for argon laser photocoagulation treatment. The presence of well-developed cystoid maculopathy suggests that visual acuity may not return to 20/20 even when all leakage sites have been obliterated and all edema reabsorbed. On the other hand, control studies have shown that photocoagulation in such patients may reduce the rate of visual deterioration. Slide 26. Argon laser photocoagulation of simple diabetic macular edema. This 60-year-old white female with a 9-year history of diabetes recently noted metamorphopsia left eye. Visual acuity was 20/40. Upper left, note microaneurysms and lipid in fovea. Upper center, microaneurysms fluoresce 21 seconds after dye injection. Parafoveal capillary rim is intact and there are no major areas of capillary closure. Upper right, 20 minutes after dye injection, cystoid maculopathy is apparent. Because visual acuity was reduced by macular edema and because leaking capillaries were clearly identifiable on the fluorescein angiogram, this patient was treated with argon laser photocoagulation. Each leaking microaneurysm was coagulated using the 50-micron beam diameter at sufficient power to produce moderate whitening. Exposure time was 0.1 and 0.2 seconds. Lower left is a photograph taken immediately after photocoagulation. 3 months after treatment, visual acuity improved to 20/20 and has remained 20/20 for 3 years. Lower center and lower right photographs were taken 3 years after treatment. The 2 microaneurysms that fluoresce in the post-treatment angiogram, lower right, did not leak in the late phase of the angiogram. Staining of chorioretinal scars is also seen in the post-treatment angiogram, lower right. Comment: this patient had a favorable prognosis for improved vision following photocoagulation because of the following factors. Visual reduction was modest. There was no lipid in the central fovea. There was good parafoveal capillary perfusion. Leakage sites were clearly identifiable on the fluorescein angiogram. Cystoid maculopathy in general is not a favorable prognostic factor, but but in this case it did not have a deleterious influence on the visual outcome, probably because the cystoid had not been present for a long time and because a lamellar hole was not present. This patient was photocoagulated on only one occasion, but many patients require 2 or more separate treatment sessions, 1 to 2 months apart, before all microvascular abnormalities causing macular edema are obliterated. Even in the favorable cases, visual improvement may not occur until several months after resolution of macular. Cystoid maculopathy in general is not a favorable prognostic factor, but in this case it did not have a deleterious influence on the visual outcome, probably because the cystoid had not been present for a long time and because a lamellar hole was not present. This patient was photocoagulated on only one occasion, but many patients require 2 or more separate treatment sessions, 1 to 2 months apart, before all microvascular abnormalities causing macular edema are obliterated. Even in the favorable cases, visual improvement may not occur until several months after resolution of macular edema, so neither the patient nor the ophthalmologist should be impatient. Slide 27. Photocoagulation treatment of circinate retinopathy. This 64-year-old black female with aphakia and a 15-year history of diabetes had complained of blurred vision in the right eye for 3 months. Visual acuity was 20/40. Upper left, note lipid ring temporal to fovea with microaneurysms and telangiectatic vessels inside lipid ring. Hard exudate encroaches on central fovea. Upper right, 23 seconds after dye injection, note preponderance of vascular abnormalities are seen inside lipid ring. Lower left, 15 minutes after injection, note extensive dye leakage into retina and cystoid maculopathy. Argon laser photocoagulation burns were applied in nearly confluent fashion inside lipid ring and to all microaneurysms and telangiectatic vessels outside lipid ring, causing macular edema. 1 year after treatment, lower right, note pigmented photocoagulation scars and complete reabsorption of lipid. Visual acuity improved to 20/20. Comment: vascular abnormalities are invariably found inside the center of a lipid ring. It is important to recognize that the entire area within the lipid ring is edematous, not just the hard exudate. As one proceeds centrifugally from the abnormal leaking vessels at the center, there is some reabsorption of edema. The yellow hard exudate represents lipid and lipoproteins, some of which may have been engulfed by macrophages. This material is less readily reabsorbed than simple transudate. Even after complete closure of all leaking microvascular abnormalities, many months may be required until all the lipid is reabsorbed. We believe that it is important to photocoagulate vascular abnormalities in patients with circinate retinopathy before lipid has reached the center of the fovea in order to maximize the opportunity for restoration and preservation of visual acuity. You may refer to the monograph for a more detailed account of the results of photocoagulation for diabetic macular edema as demonstrated in 2 randomized studies. Slide 28. Cotton wool spots and focal capillary closure. This 31-year-old white male had diabetes diagnosed at age 12 years. 6 months ago, he developed labile hypertension. Systolic pressure ranged between 150 and 200 millimeters of mercury, and diastolic pressure between 90 and 120 millimeters of mercury. Visual acuity was 20/20 in each eye, but he complained of intermittent blurred vision. Upper left, note multiple cotton wool spots, which represent microinfarcts in the nerve fiber layer and are due to focal capillary closure. Upper center, cotton wool spots are well delineated in red-free photograph. Arrow points to intraretinal microvascular abnormalities, inferonasal to center of macula. Upper right, 12 seconds after dye injection, note focal areas of capillary closure corresponding to cotton wool spots. Lower left, 6 seconds later, the areas of capillary closure are sharply defined. Arrow points to typical intraretinal microvascular abnormality, or IRMA, adjacent to area of capillary closure. Lower center, 35 seconds after injection, note diffuse dye leakage from multiple intraretinal microvascular abnormalities. Lower right, 10 minutes after injection, note marked dye leakage has occurred throughout posterior pole. Comment: at one time, cotton wool spots were considered the hallmark of hypertensive retinopathy. They also occur frequently in diabetic retinopathy in non-hypertensive patients. Several years ago, Kohner showed that ophthalmoscopic fading of the cotton wool spot is often associated with angiographic evidence of revascularization of the ischemic area of retina. Extensive capillary closure in the diabetic patient is often the harbinger of proliferative retinopathy. In fact, 2 months after these photographs were taken, this patient was found to have developed retinal neovascularization from areas of capillary closure. Slide 29. Pathogenesis of proliferative retinopathy. We have done serial fluorescein angiograms in diabetic patients prior to the development of proliferative retinopathy. This 19-year-old white female with a 7-year history of diabetes had visual acuity of 20/20. All photographs are of the superior temporal fundus, right eye. The photographs above are from July 1974, and photographs below are from January 1975. For orientation, arrows point to same AV crossing in all 4 photographs. Upper left, 15 seconds after dye injection, note hyperfluorescence of intraretinal microvascular abnormalities and extensive areas of retinal non-perfusion. Upper right, note early dye leakage into retina from microvascular abnormalities. Lower left, 6 months later, note development of neovascularization in area of retinal non-perfusion. Lower right, 1 minute after injection, note marked dye leakage into retina. Comment: this patient illustrates the development of neovascularization from areas of retinal non-perfusion. Capillary closure causes retinal ischemia. Ischemic retina presumably elaborates a soluble polypeptide, which some have called neovascularization-producing substance. This substance apparently stimulates the retina to produce new blood vessels. As in all proliferative retinopathies, new blood vessels grow at the interface of perfused and non-perfused retina. Slide 30. Optic atrophy and proliferative retinopathy. This 51-year-old white female has had diabetes for 19 years. 6 years ago, central retinal artery occlusion resulted in permanent visual loss, right eye. Upper left and upper right are photographs of disc and macula, right eye, showing pallor of the nerve head, marked narrowing of arteries and veins, and complete absence of diabetic retinopathy. Lower left, in left eye, note neovascularization, vitreous hemorrhage, and multiple chorioretinal scars from prior argon laser photocoagulation. Comment: the optic atrophy in the right eye seems to have protected that eye from proliferative retinopathy. Other conditions which seem to protect an eye from proliferative retinopathy include advanced glaucoma, unilateral carotid artery stenosis, high myopia, and extensive chorioretinal scarring. Optic atrophy from any cause is the feature common to all these conditions. Several years ago, Oken observed that diabetic eyes treated with extensive photocoagulation developed optic disc pallor and had fewer recurrences of neovascularization than eyes treated with less extensive photocoagulation. Oken's observation, coupled with prior observations regarding the influence of optic atrophy on the course of proliferative retinopathy, stimulated Beetham and Aiello in the late 1960s to study the effects of ruby laser photocoagulation scattered throughout the posterior pole as treatment for proliferative retinopathy. Encouraging results from this preliminary study form the basis of using the scatter or pan-retinal photocoagulation technique in the diabetic retinopathy study. Lower right, the artist's sketch illustrates one possible mechanism of how this theory works. Eyes with normal perfusion and eyes with total optic atrophy do not generally develop neovascularization. As retinal capillaries begin to close in the diabetic eye, the retina becomes ischemic and presumably elaborates a neovascularization producing substance which results in the formation of new blood vessels on the disc and retina. Scatter photocoagulation, or PRP, produces extensive chorioretinal scarring and eventuates in narrowing of retinal vessels and partial optic atrophy, as demonstrated by disc pallor. Obliteration of areas of retinal hypoxia leads presumably to reduction in the formation of neovascularization producing substance and consequently to regression of existing neovascularization and a reduction in the tendency to develop new formed vessels. Whether or not the theory as illustrated here is correct is a debatable point, but from an operational point of view, the scatter photocoagulation treatment is effective in many cases as shown by the results of the diabetic retinopathy study. Slide 31. Retinal perfusion pattern with disc neovascularization. This patient has a characteristic pattern of retinal perfusion or non-perfusion seen in many patients with disc neovascularization. She is a 33-year-old white female who has had diabetes for 20 years. Visual acuity was 20/20 in each eye. Upper and lower left notes subtle disc neovascularization and marked whitening of retinal vessels in right and left macula, respectively. Upper and lower center note early dye leakage from disc neovascularization and extensive capillary dropout in right and left macula, respectively. Upper right, note fluorescence of iris neovascularization 12 seconds after dye injection, and lower right, note dye leakage from iris neovascularization 22 seconds after injection. Comment: extensive capillary closure has resulted in significant retinal ischemia, which has led to the development of disc neovascularization and iris neovascularization in this patient. Despite marked retinal non-perfusion in parafoveal capillaries, visual acuity was 20/20 in each eye. In patients with diabetic macular edema, capillary non-perfusion in the macula often indicates a poor visual prognosis with or without photocoagulation treatment. In patients with proliferative retinopathy but no macular edema, capillary non-perfusion in the macula is a less reliable predictor of visual acuity. Note that retinal capillaries supplying nerve fibers in the papillomacular bundle are not disturbed in this patient. Since choriocapillaris adequately nourishes the fovea, and since existing retinal capillaries adequately nourish nerve fibers in the papillomacular bundle, this patient has maintained 20/20 visual acuity in both eyes. In addition to capillary closure in the macula, fluorescein studies of the periphery demonstrated extensive capillary dropout in both eyes. Slide 32, retinal neovascularization. This 52-year-old white male pharmacist had lost 20 pounds over 3 months. Sudden loss of vision in the left eye prompted an ophthalmic consultation, at which time severe diabetic retinopathy was discovered. He was not known to be diabetic. Upper left, note dense vitreous hemorrhage in left eye. Upper center, note disc neovascularization, right eye. Arrow indicates duplication or loop formation of inferior temporal vein. Upper right, note hemorrhage and lipid in macula, which reduced visual acuity to 20/50. Lower left, note marked beading or sausage-like appearance of veins, small vitreous hemorrhage, and extensive capillary dropout. Essentially, no vessels are seen other than major arteries and veins. Lower center, small arrows indicate venous loops. Large arrow points to retinal neovascularization beneath preretinal hemorrhage. Lower right, note venous loop nasal to disc, retinal neovascularization surrounding venous loop, and marked retinal non-perfusion. Arrow points to obliterated retinal arteriole. In this case, fluorescein studies are not required to document the presence of extensive retinal non-perfusion. Retinal and disc neovascularization have resulted from profound retinal ischemia caused by extensive capillary closure. The remarkable feature in this patient's history is that diabetes was not discovered until after severe vitreous hemorrhage in the left eye. The patient was unaware of reduced vision in the right eye, which had both macular hemorrhage and extensive neovascularization. The right eye was treated with scatter argon laser photocoagulation in an attempt to obliterate areas of retinal hypoxia and promote regression of neovascularization. If vitreous hemorrhage left eye has not cleared in 1 year, he may be a candidate for pars plana vitrectomy. Slide 33. Scatter xenon arc photocoagulation for disc neovascularization. This 67-year-old white female has had diabetes for 35 years. Visual acuity left eye was reduced to 20/40 because of macular lipid. Upper left, note extensive surface and intravitreal disc neovascularization. Upper right, note marked dye leakage from disc vessels 1 1/2 minutes after injection. Lower left, note scatter pattern of xenon arc photocoagulation. Multiple 4 1/2 degree lesions were scattered throughout the posterior pole, extending out to the equator. No treatment was applied directly over the disc neovascularization. Lower right, 2 months following treatment, note complete regression of disc neovascularization. Macular lipid was unchanged and visual acuity remained 20/40. Comment. The diabetic retinopathy study demonstrated that xenon arc and argon laser photocoagulation performed in scatter fashion as demonstrated here are equally effective in reducing the risk of recurrent vitreous hemorrhage and subsequent visual loss in patients with neovascularization on the disc. As reported in the April 1976 issue of the American Journal of Ophthalmology, however, There was more visual field loss in patients treated with xenon arc photocoagulation than in eyes treated with argon laser photocoagulation in the patients participating in the diabetic retinopathy study. The patient illustrated here demonstrates remarkable regression of disc new vessels following scatter xenon arc treatment. Slide 34. Scatter argon laser photocoagulation for diabetic neovascularization. This 38-year-old white female has had diabetes for 20 years. Visual acuity was 20/20 in each eye. Fundus examination disclosed disc neovascularization and retinal neovascularization in both eyes. Upper left, note disc neovascularization in photograph taken immediately after scatter argon laser photocoagulation. Note that no photocoagulation burns were applied directly over disc vessels. Upper center, note marked dye leakage from disc neovascularization. Upper right, note marked regression and beginning fibrosis of disc vessels just 8 days following scatter photocoagulation. Lower left, red-free photograph demonstrates retinal neovascularization inferotemporal to fovea prior to treatment. Lower center, note that scatter photocoagulation surrounded this area of retinal neovascularization, but that no photocoagulation was applied directly overlying retinal neovascularization. Lower right, 6 months following treatment, note persistence of retinal neovascularization. Comment: in some instances, scatter photocoagulation treatment will cause regression of retinal neovascularization as well as disc neovascularization. This case demonstrates, however, that in some patients, focal treatment to retinal neovascularization may be required to obliterate retinal new vessels and thereby reduce the likelihood of vitreous hemorrhage. Slide 35. Focal argon laser photocoagulation for retinal neovascularization. This 51-year-old white male had proliferative diabetic retinopathy in both eyes. In the right eye, epiretinal membranes and fibrous tissue, upper left, precluded focal argon laser photocoagulation. Upper center, note retinal neovascularization temporal to the fovea, left eye. Upper right, note early dye leakage from retinal neovascularization and marked non-perfusion distal to neovascularization. As usual, new vessels appear at the interface between perfused and non-perfused retina. Lower left, note retinal whitening and fragmentation of neovascular channels in photograph taken immediately after photocoagulation. Scatter photocoagulation extending to the equator was applied in addition to focal treatment of new vessels. Lower center, note chorioretinal scars in place of neovascularization 1 month after treatment. Lower right, note absence of new vessels 1 year after treatment. Comment: epiretinal membrane formation and fibrous proliferation accompanying new vessels precludes focal photocoagulation treatment, as in this patient's right eye. Some eyes with fibrous proliferation may benefit from scatter photocoagulation treatment in an effort to reduce the vascular component of the proliferative retinopathy. This patient's left eye had neovascularization not accompanied by significant fibrous tissue, and the new vessels were closed with focal argon laser photocoagulation. New vessels have not reappeared 2.5 years following treatment. Slide 36. Recurrence of disc neovascularization after photocoagulation. This 54-year-old white female has had diabetes for 21 years. Visual acuity was 20/20. Upper left, note disc neovascularization prior to photocoagulation treatment. Upper right, note pattern of scattered argon laser photocoagulation treatment. Lower left, note regression of disc vessels 1 month following treatment. Lower right, Note reappearance of disc neovascularization 1 year following treatment. Comment: although scatter photocoagulation treatment often promotes regression, if not complete disappearance, of disc neovascularization, follow-up examination in this case showed recurrence of disc vessels 1 year later. This case demonstrates that careful follow-up at 4 to 6 month intervals is mandatory for all patients with proliferative diabetic retinopathy. In some instances, additional scatter photocoagulation may promote regression of disc neovascularization. Slide 37. Focal xenon arc photocoagulation for retinal neovascularization. This 31-year-old white female has had diabetes for 13 years. She has had prior xenon arc photocoagulation treatment as indicated by the pigmented chorioretinal scars seen in both photographs. On the left, note that retinal whitening immediately following xenon arc photocoagulation enhances the visibility of the retinal neovascularization. In the right photograph, taken 6 weeks following treatment, arrows point to photocoagulated areas. Note that no neovascularization is visible. Comment: in the treatment of retinal neovascularization with argon laser photocoagulation, it is important to achieve fragmentation of the vessels at the time of treatment. If one fails to achieve fragmentation at the time of treatment, it is almost certain that the vessels will not close later. On the other hand, when utilizing the xenon arc modality, one often does not achieve fragmentation at the time of treatment. However, because the intensity of the xenon arc burn is considerably greater than that of the argon laser burn, it is customary to observe complete closure of retinal neovascularization 3 to 6 weeks following xenon arc photocoagulation treatment. In this patient, fragmentation was not achieved at the time of treatment, but 6 weeks later, the vessels were noted to be closed. As in the previous slide, this patient developed retinal neovascularization after initially successful xenon arc photocoagulation. Thus, it is important that careful fundus examination be performed at 4 to 6 month intervals in the patient with proliferative retinopathy. Slide 38. Spontaneous regression of disc neovascularization with 5-year follow-up. This 22-year-old white male with an 18-year history of diabetes had visual acuity of 20/20 in each eye. In 1971, there was marked disc neovascularization in both eyes as seen in the photographs on the left. Following scatter argon laser photocoagulation to the right eye, disc new vessels regressed almost completely, and the right eye has remained asymptomatic for 5 years. Upper right is appearance of right disc 5 years after treatment. Until the preliminary results of the diabetic retinopathy study were published, our practice was to photocoagulate only one eye of patients with proliferative retinopathy. Thus, the left eye in this patient received no photocoagulation treatment. In fact, the left eye had more extensive disc neovascularization than the right eye initially. 1 year after the initial examination, disc neovascularization in the untreated left eye disappeared completely. The lower right photograph was taken 5 years after the lower left photograph and shows that disc neovascularization has not returned during a 5-year follow-up. Comment: the variable course of proliferative diabetic retinopathy was one factor which mandated the initiation of a randomized clinical trial, the diabetic retinopathy study. It was often quoted that up to 10% of patients with proliferative retinopathy had spontaneous regression of neovascularization. While we believe that this figure is probably inflated, the patient illustrated here demonstrates remarkable spontaneous regression of florid disc neovascularization in the untreated left eye. Slide 39. Advanced proliferative retinopathy with traction detachment. This 19-year-old white female has had diabetes since age 2. She was examined elsewhere in December 1975, at which time visual acuity was 20/30 in both eyes. Fluorescein angiography showed diffuse capillary changes throughout the posterior pole of both eyes and early disc neovascularization in both eyes. Within 2 weeks, while waiting to be scheduled for photocoagulation treatment, she developed vitreous hemorrhage and traction detachment in both eyes. Upper left, note advanced disc neovascularization, traction detachment, and vitreous hemorrhage in a photograph taken in the region of the right optic disc. Upper right, note superior temporal fundus, right eye, with marked fibrovascular proliferative retinopathy. Lower left, in photograph taken of macular region, again note marked fibrovascular proliferation and traction detachment. Lower right, photograph of more peripheral area of fundus shows that traction detachment extends out towards equator. Comment. In patients with disc neovascularization, particularly those with diffuse capillary abnormalities involving the entire posterior pole, the onset of vitreous hemorrhage and retinal detachment may develop very rapidly. It is important, therefore, to proceed with scatter photocoagulation treatment without undue delay before the onset of secondary complications which may preclude permanently the possibility of photocoagulation treatment. Progressive deterioration of diabetic retinopathy may occur despite photocoagulation treatment, but as the diabetic retinopathy study has shown, the risk of blindness from recurrent vitreous hemorrhage and retinal detachment is markedly reduced in patients with disc neovascularization who are treated with scatter photocoagulation. This completes the discussion on diabetic retinopathy. We now turn to the subject of retrolental fibroplasia. Despite our increased understanding of the pathogenesis of this disorder, new cases still occur. Arnold, since you performed the first controlled study in the nursery on oxygen treatment, and since you have produced the disease in experimental animals, it is appropriate that you narrate this section.
Slide 40. Developmental pattern of retinal vascularization. To help us understand the pathogenesis of retrolental fibroplasia, we first review the normal development of retinal vascularization. The retina is unique in that it has no blood vessels until the 4th month of gestation, when vascular complexes emanating from the hyaloid vessel at the optic disc grow towards the periphery. Vessels reach the nasal periphery N at 8 months gestation. The temporal periphery, T, is not fully vascularized until approximately 1 month after delivery, even in the full-term infant. It has been adequately demonstrated in animal models that it is the incompletely vascularized retina that is susceptible to oxygen damage and subsequent development of RLF. This pattern of normal vascularization, therefore, explains the increased susceptibility to RLF for the more premature infant and the special predilection of RLF for the temporal periphery. Slide 41. Mechanism of oxygen action on the immature retina. The response of immature retinal vessels to increased oxygen levels can be conveniently divided into 2 stages, as depicted in the artist's sketch. On the left, note that the primary effect of oxygen on the immature retina is retinal vasoconstriction. If vasoconstriction is sustained, vasoobliteration and permanent capillary closure of more peripheral vascular complexes result. On the right, note that the secondary response to oxygen exposure occurs after removal to room air. In the area immediately adjacent to vascular obliteration, intraretinal neovascularization develops. Further proliferation of these vessels through the internal limiting membrane results in classical surface and intravitreal neovascularization. Indeed, the neovascularization seen in the experimental model is virtually indistinguishable from the intravitreal neovascularization observed in early active human retrolental fibroplasia. Slide 42. Fluorescein angiography and proliferative retrolental fibroplasia. Flynn and co-workers in Miami first introduced fluorescein fundus photography as a method of evaluating and following infants with RLF. Upper left, artist diagram, modified from Flynn, shows findings in secondary or proliferative RLF following removal to room air. Note zone of capillary closure produced by initial exposure to oxygen. Anterior to area of capillary closure, shunting between arteriolar and venular branch vessels has been designated by Flynn and co-workers as a mesenchymal shunt. Adjacent to area of capillary closure, note neovascularization. Upper right, short arrows denote mesenchymal shunt at border of vascularized retina. Peripheral to this shunt is area of retinal non-perfusion. Long black arrow points to patches of intravitreal neovascularization. Lower left, 16 seconds later in dye transit, note very minimal leakage from border of mesenchymal shunt vessels. Arrow indicates prominent leakage from intravitreal neovascularization. Lower right, 13 seconds after photograph on lower left, note further dye leakage from intravitreal neovascularization and slight increase in leakage from mesenchymal shunt vessels. Slide 43. Acute proliferative RLF, stage 2 active. This premature infant was born at 6.5 months gestation and had a birth weight of 1 pound 15 ounces. He was first examined at age 3 months. Upper left, in temporal periphery near the equator, note proliferation of vessels just posterior to demarcation line between vascularized retina V and avascular retina A. Upper right, fluorescein angiography provides better resolution of neovascularization. Short arrows show nodules of neovascularization. Long arrow points to vessels which have extended past the zone of neovascularization. Flynn and co-workers have suggested that when retinal vascularization penetrates this demarcation zone to vascularize the retina more anteriorly, spontaneous regression has started. This has also been our experience in several cases. Lower left, photograph of opposite eye shows temporal periphery just posterior to equator. Note retinal hemorrhage just posterior to area of retinal vascular proliferation. Lower right, clear scene angiogram in mid-transit shows extensive dye leakage from zone of neovascularization. Arrow points to retinal hemorrhage, which blocks underlying choroidal fluorescence. Note that dye leakage is confined to area of neovascularization. Slide 44, progression of active retrolental fibroplasia. This premature infant, with a birth weight of 2 pounds 4 ounces, was born after 7 months gestation and was found to have active proliferative RLF. Upper left, in temporal periphery near equator, note intravitreal neovascularization just posterior to demarcation line between vascularized retina V and the more anterior avascular retina A. Arrow points to globular-like bodies, which on histologic section are nodules of proliferating endothelial cells. Upper center, note dilatation and tortuosity of the major retinal vessels near the disc. Arrows indicate normal arching pattern of the temporal vascular arcade over the macula. Upper right, 3 weeks after previous photographs were taken, traction from temporal periphery has straightened major temporal vessels so that they now take on a V pattern instead of the normal arcuate appearance. Lower left, 3 weeks after photograph on upper right, note further traction on temporal vessels. Lower center, 2 months later, additional traction from temporal periphery has produced the classical dragged disc, or as more appropriately designated by Tasman, the dragged retinal vessel appearance. This results in marked temporal displacement and heterotopia of the macula with serious visual impairment. Lower right, left eye of same patient with cicatricial stage 1 RLF. Arrow points to elevated ridge of tissue at site of proliferative lesions. Slide 45, active peripheral RLF with normal posterior pole. This 4-month-old white female had a birth weight of 2 pounds 12 ounces and a gestational age of 7.5 months at birth. She illustrates the need for indirect ophthalmoscopy to resolve peripheral lesions. On the left, note that posterior pole is essentially normal. There is a very minimal degree of retinal vessel tortuosity, which is certainly not beyond normal limits. This area of the photograph is the approximate field of view obtained with the direct ophthalmoscope. On the right, temporal periphery of the same eye shows active RLF at the border of the vascularized and avascular retina. Arrow points to tufts of neovascular proliferation. Slide 46, cicatricial or arrested stage 2 RLF. This 9-year-old white female had a birth weight of 4 pounds 6 ounces and a gestational age of 7.5 months at birth. She was treated for unexplained strabismus and used miotic drops for crossed eyes. Her parents were told of nonspecific retinal scars in each eye. Shortly prior to examination at Wilmer, she experienced a major vitreal hemorrhage in the left eye. Refraction revealed 10 diopters of myopia in the right eye. With glasses, visual acuity corrected to 20/200, right eye. Vitreal hemorrhage, left eye, limited vision to light perception only. Upper left, note myopic conus on temporal margin of disc. Upper right, in nasal periphery, posterior to equator, note large retinal scar. Lower left, in angiogram of temporal periphery, just posterior to the equator, note classical telangiectatic-like vascular arcade. This type of vascular abnormality is common in arrested retrolental fibroplasia and represents the most anterior extent of retinal vascularization that is ever achieved. Lower right, 5 seconds later in dye transit, note early leakage from abnormal retinal vessels. Slide 47, arrested cicatricial RLF. This 18-year-old white male was one of twins who was born 2 months prematurely with a birth weight of 4 pounds 12 ounces. The right eye showed a stage 5 total membrane and had no light perception. The left eye showed arrested RLF, stage 3, with a temporal retinal detachment. Visual acuity, left eye, was 20/200. On the left, note marked dragging of vessels across the temporal border of disc and loss of arcuate pattern of temporal vessels. In center photograph, just temporal to the macula, note traction detachment extending toward the temporal periphery. In right photograph, note large elevated retinal detachment in temporal periphery. Comment. This patient illustrates the asymmetric findings that are frequently noted in cicatricial retrolental fibroplasia and also provides an example of the increased incidence of RLF in twins. Slide 48. Arrested RLF with heterotopia of macula and pseudoexotropia. This 26-year-old white female was born 7 weeks prematurely during the RLF epidemic in the early 1950s. Birth weight was 2.5 pounds. Oxygen therapy was administered for 3 weeks without measurement of incubator oxygen concentration. Visual acuity was 20/70 right eye and 5/200 left eye. Upper left, external photograph shows pseudoexotropia. On cover test, there is no movement of the eyes. Exotropic position results from external rotation of the globe to compensate for the lateral displacement of the macula. Upper center, photograph of right eye shows marked temporal displacement of retinal vessels, which are dragged across disc, and marked heterotopia of macula results. Upper right, photograph of left eye also shows marked heterotopia of macula and temporal dragging of retinal vessels. Lower left, loss of pigment from RPE enhances visualization of larger choroidal vessels. Hyperfluorescence in papillomacular bundle area results from permanent damage to retinal capillary integrity. Also, note marked temporal displacement of vessels. The left eye showed the same findings. Lower center, in temporal periphery of left eye, note marked loss of pigment in RPE, causing a window defect with increased choroidal fluorescence delineated by arrows. Details of choroidal vasculature are visible. Lower right, 2 seconds later, normal leakage of dye into choroidal space increases hyperfluorescence and obscures choroidal vascular details. Slide 49, Stage 5 cicatricial RLF, clinical and pathological features. Upper left is Stage 5 cicatricial RLF with total detachment of the scarred retina presenting as a white membrane in each pupil. There is no light perception in either eye. Advanced RLF is an important cause of leukocoria or white pupil. The differential diagnosis of leukocoria is discussed in the accompanying monograph. Upper right, is another example of stage 5 bilateral cicatricial RLF. The child is totally blind. The right pupil is bound down to the lens by posterior synechia, and the iris lens diaphragm is bulged forward, shallowing the anterior chamber. The left pupil dilates normally, and the anterior chamber is normal depth. Lower left, in a histologic section from a similar patient with stage 5 RLF, arrows point to total detachment of retina. The position of a totally detached and fibrotic retina, and Terry's assumption that the lesion was a fibrous proliferation of the hyaloid system that incorporated the retina, prompted the term retrolental fibroplasia. Lower right is a higher magnification of the histologic section shown lower left. Note marked fibrosis and gliosis with disorganization of the detached retina. The destruction of the retina explains why operations to cut a window in the white membrane were doomed to failure. Slide 50. Sequential follow-up of acute RLF. This child was a 2.5 months old white male at the time of initial examination. The history revealed a birth weight of 2.5 pounds and a gestational age of 7 months. Upper left, temporal periphery, left eye, shows preretinal hemorrhage from area of neovascularization. Arrow points to junction of vascularized and avascular retina. Peripheral avascular retina has typical milky or translucent appearance, whereas vascularized retina shows normal orange color. Upper center, in fluorescein angiogram taken same day as upper left photograph, note area of non-perfusion temporally where retina is avascular. Arrow denotes mesenchymal shunt at edge of vascularized zone of retina connecting arteriolar and venular branch vessels. Note mild hyperfluorescence along zone of shunt vessels, indicating slight loss of endothelial cell integrity. Upper right, 6 minutes later in diatransit, note prominent fluorescein leakage. Arrow points to retinal hemorrhage seen in color photograph, which blocks underlying choroidal fluorescence. Lower left, in angiogram of same eye taken 10 weeks after photographs above, note telangiectatic-like terminal vessels in vascularized portion of the temporal retina. Lower center, fluorescein angiogram is taken 6 months after photograph on lower left. Child is now 1 year of age. Note lack of vascularization in temporal periphery. Arrow points to large anastomotic vessel not filled with dye at this stage of angiogram. Lower right, photograph taken several months later, shows late filling of this vessel and subtle dye leakage. This completes the section on retrolental fibroplasia. Stewart, will you now discuss the subject of retinal telangiectasias?
Slide 51. Telangiectasis without exudate or edema. This 56-year-old white male was found to have microaneurysms at the posterior pole of the left eye on routine ophthalmic examination. Visual acuity was 20/20 in each eye. He did not have diabetes mellitus, hypertension, or other systemic disease. Positive findings were limited to the left macula. Upper left, note several microaneurysms adjacent to the left fovea. Upper right, 9 seconds after dye injection, note multiple microaneurysms with small area of capillary closure adjacent to microaneurysms. Lower left, 30 minutes after injection, note staining of one large microaneurysm. Note that no dye has spread into retina. Lower right, artist's sketch illustrates telangiectatic capillaries in middle retinal layers. Comment: this patient has been followed for 3 years without change in visual acuity or fundus pathology. He has not developed evidence of diabetes, hypertension, or other systemic disease. This is the most subtle vascular abnormality we have seen that is consistent with a morphologic diagnosis of retinal telangiectasis. No treatment is recommended in view of 20/20 acuity and lack of progression in fundus pathology. Slide 52. Telangiectasis with cystoid macular edema. This 49-year-old white male complained of blurred vision left eye for 3 months. There was no evidence of diabetes, hypertension, or systemic disease. Visual acuity was 20/15 right eye and 20/40 left eye. Right eye was normal. Upper left, note microaneurysms in left macula. Upper right, artist's sketch shows dilated capillaries in middle retinal layers. Lower left, note hyperfluorescence of microaneurysms and dilated capillaries 30 seconds after injection. Lower right, 30 minutes after injection, note cystoid macular edema. Comment: this patient had reduced vision due to cystoid macular edema. Vascular abnormalities causing macular edema were clearly visible on the angiogram. He is a candidate for argon laser photocoagulation, the technique of which will be illustrated in slide 58. Slide 53. Telangiectasis with circinate retinopathy, posterior pole. On routine ophthalmoscopic examination, this 52-year-old white male was found to have a lipid ring in the left macula. Visual acuity was 20/16 in each eye. The media were clear and the right fundus was normal. Upper left, note area of lipid in circinate pattern superotemporal to left fovea. Vascular abnormalities inside lipid ring are readily appreciated on red-free photograph, upper center. Artist's drawing, upper right, shows telangiectatic capillaries in middle retinal layers and lipid in outer plexiform layer, the characteristic location of lipid deposition from leaky retinal capillaries. Lower left, note dilated capillaries 30 seconds after dye injection. Lipid ring partially obstructs background choroidal fluorescence. Lower center, 1 minute after injection, note beginning dye leakage into retina. Lower right, 30 minutes after injection, persistent hyperfluorescence indicates retinal edema. Comment: when a patient presents with macular lipid and retinal vascular abnormalities, hypertension and diabetes should be considered. Neither was found in this patient. He has been followed 2 years without change in fundus appearance. Vision remains 20/16. No treatment is recommended at present. Should he develop visual loss in the left eye due to edema or exudate involving the fovea, argon laser photocoagulation would be directed to leaking capillaries causing lipid deposition and macular edema. Since many patients with retinal telangiectasis go for years without visual loss, they should be followed without treatment unless visual loss is documented. Slide 54. Telangiectasis with peripheral circinate retinopathy. This 42-year-old white male sought ophthalmic consultation because of symptoms in the left eye due to posterior vitreous detachment. Visual acuity was 20/16 in each eye, and there was no history of systemic disease. Media were clear in both eyes, and the right fundus was normal. Fundus examination left eye disclosed a normal posterior pole and 2 areas of circinate retinopathy inferiorly. On the left, note aneurysmal dilatation of vessels passing through center of larger lipid ring. Remember that entire area within lipid ring is edematous. On the right is second lipid ring, located 3 disc diameters nasal to cercinate pattern, seen left. This lipid is also located in middle layers of the retina. Note absence of vessels peripheral to inferior edge of lipid. Arrow points to green area in center of lipid ring. This probably represents subretinal lipid with secondary migration of pigment from RPE. Comment: because this patient was asymptomatic and because there was no macular involvement, no treatment was recommended. He has been followed 1 year without change in vision or fundus appearance. If he develops a marked increase in lipid deposition, or should he become symptomatic as a result of macular involvement, photocoagulation treatment would be directed towards abnormal vascular lesions in the central portion of the lipid rings. It is interesting to follow these lesions with serial photographs. Slide 55. Telangiectasis with peripheral and macular exudates. This 10-year-old black male recently complained of decreased vision in the left eye. Visual acuity was 20/16 right eye and 20/80 left eye. The right eye was entirely normal. Upper left, note star figure and fibroglial nodule in center of left macula. There is considerable lipid deposition throughout posterior pole as seen upper center. Upper right, note multiple areas of telangiectasis involving both arterioles and capillaries. Lower left, fluorescein angiography of left macula. Small arrow shows early staining of fibroglial nodule, and large arrow indicates leaking telangiectatic vessels inferotemporal to the fovea. Lower center, note dye leakage from telangiectatic vessels and areas of capillary closure adjacent to telangiectatic vessels. Lower right, in trypsin digest preparation from another patient, arrow in center of non-perfused retina points to large aneurysmal dilatation. To the right of this large aneurysm are ghost capillaries without identifiable endothelial cells or pericytes. Comment: the presence of a fibroglial nodule in the central fovea indicates chronicity and a rather poor visual prognosis, since the sensory retinal elements have likely been damaged irreversibly. Photocoagulation treatment to areas of peripheral telangiectasis may reduce further lipid deposition in the macula, however. In time, the macular lipid may be reabsorbed and further visual deterioration may be halted. Slide 56. Disciform macular scar and peripheral telangiectasis. This 6-year-old black male presented with leukocoria of the right eye. Visual acuity was 3/200 right eye and 20/20 left eye. Media were clear in both eyes and the left eye was entirely normal. Upper left, note dense white nodule in right macula. Upper right, nodule stains with fluorescein 2 minutes after dye injection. Lower left, in histologic section from another patient with similar clinical findings, large arrow points to disorganized retina, and small arrow lies in center of fibrous tissue which has replaced sensory retinal elements. Lower right, in fluorescein angiogram of retinal periphery, note characteristic retinal vascular abnormalities. In addition to telangiectatic vessels, note capillary closure adjacent to and peripheral to dilated vascular bed. Comment: no treatment can be expected to improve visual acuity in this patient. It is impossible to know from fluorescein angiography whether this patient also had vascular abnormalities at the posterior pole or whether the lipid deposition in the macula resulted from peripheral telangiectasis only. Many patients with macular lipid do not show vascular abnormalities in the macula. It is not clear in such cases why lipid accumulates at the posterior pole at a site remote from peripheral vascular lesions. Gass has theorized that during sleep, the recumbent position may favor accumulation of retinal transudate and exudate at the posterior pole of the eye. Lacking an experimental animal model, it is virtually impossible to document this hypothesis. Slide 57. Xenon arc photocoagulation for retinal telangiectasis. This 47-year-old white male complained of reduced vision left eye for 3 months. Right eye vision was 20/20 and the fundus was normal. Left eye vision was 20/40 because of macular edema. Upper left, note lipid deposition temporal to the fovea. Upper center, note telangiectatic vessels just temporal to the lipid. Note that abnormal vessels are not seen within the macula. Upper right, fluorescein angiography shows multiple dilated vascular channels, most of which leak dye in later stages of angiogram. Lower left photograph was taken after mild intensity xenon arc photocoagulation was applied to peripheral retinal vascular abnormalities. Lower center, 1 year later, note chorioretinal scars in place of retinal vascular lesions. At the same time, note resolution of macular lipid, lower right. Vision improved from 20/40 to 20/20 and has remained 20/20 for 7 years. Slide 58. Argon laser photocoagulation for retinal telangiectasis. This 49-year-old white male, also shown in slide 52, had 20/40 vision left eye. Upper left, note multiple microaneurysms surrounding fovea. These dilated vascular segments are better appreciated on the angiogram upper right. Lower left is a photograph taken immediately following argon laser photocoagulation treatment, during which 100 micron diameter coagulations were directed to each microaneurysm visible on the fluorescein angiogram. Lower right is a photograph 3 years following treatment in which no microaneurysms are visible. A fluorescein study at this time showed no dye leakage. Visual acuity improved to 20/20 and has remained 20/20 for 4.5 years since treatment. Comment. For patients with vascular abnormalities in the macular region, we prefer argon laser photocoagulation because of the slit lamp delivery system and the smaller coagulations that can be delivered. For peripheral telangiectatic vessels, either xenon arc or argon laser photocoagulation treatment may be used effectively, the only consideration being adequacy of treatment. More than one treatment episode may be required regardless of which modality is used. Furthermore, the surgeon should recognize that it may take several months for the lipid to reabsorb, particularly if it has been present for a long time. Slide 59. Retinal vasculitis, intraocular inflammation, and membrane on pars plana. This 26-year-old white male presented in May 1975 with bilateral vitreous hemorrhage and good visual acuity. Initially, fundus details in the right eye could not be photographed because of diffuse vitreous blood, upper left. When the media cleared 1 month later, photographs above the right disc, upper center, and upper right showed marked attenuation of retinal vessels, retinal and vitreous hemorrhage, and perivenous sheathing. At this visit, large KP were present in the left eye, and white membranes were seen over the inferior pars plana, both eyes. Lower left, note dye leakage into retina, staining of vascular endothelium, and widespread capillary non-perfusion. Lower center, note vascular narrowing and perivenous sheathing in left macula. A fluorescein study of this area, lower right, shows staining of the vessel walls and dye leakage into the retina. Comment. This patient demonstrated physical signs of an inflammatory vasculitis and of a non-inflammatory occlusive vasculopathy. At the first examination, he appeared to have typical Eales disease. 1 month later, he had findings consistent with pars planitis. This patient's course suggests that these two entities may well be related with idiopathic inflammation of retinal vessels as the common underlying feature. Slide 60, pars planitis. This 45-year-old white female has complained of reduced vision and metamorphopsia for 3 years. Her ophthalmologist mentioned that there was dandruff in both eyes, but no diagnosis was given and no treatment was recommended. She continued to lose vision. When examined in February 1976, visual acuity was 20/70 right eye and 20/40 left eye. There was no evidence of inflammation in the aqueous or vitreous in either eye. The ophthalmoscopic findings in the macula were unremarkable and showed only a loss of the foveal reflex, upper left and lower left. However, fluorescein angiography showed dilatation of the parafoveal capillaries in the mid-stages of the angiogram, upper and lower center, and definite cystoid maculopathy 20 minutes post-injection, upper and lower right. Cystoid edema was also seen with fundus contact lens examination. In addition, white membranes on the inferior pars plana were present in both eyes. Comment: despite the absence of cells in the aqueous or vitreous, this patient clearly represents an example of pars planitis syndrome. She was placed on 80 milligrams of prednisone daily, and within 1 week, vision had improved to 20/40 right eye and 20/25 left eye. Subsequently, steroids were tapered to 0, at which time visual acuity fell. Alternate day steroid therapy in a dosage of 30 milligrams has maintained visual acuity in the range of 20/25 in each eye. She has not developed a cataract. Efforts are being made to reduce steroid dosage further. Patients with pars planitis who have visual loss due to cystoid macular edema may benefit from a short trial of systemic steroids. If visual acuity does not improve in 7 to 10 days, we discontinue steroids. If visual acuity does improve, we taper to the lowest dosage, which maintains reasonably good acuity. Slide 61. Idiopathic retinal vasculitis of the posterior segment with cystoid macular edema. This 14-year-old white male represents the mildest form of retinal vasculitis that is part of the spectrum of pars planitis syndromes. He has had recurrent episodes of decreased vision in the right eye for 9 months. On each occasion, visual acuity in the right eye was reduced to the 20/80-2200 range because of minimal macular edema. During each exacerbation, he was treated with prednisone, 30 milligrams daily. This therapy improved vision to 20/20 within 7 to 10 days, at which time the steroids were tapered. Whenever prednisone was reduced to less than 5 milligrams every other day, there was a recurrence of visual loss, at which time steroid dosage was increased. At no time was there evidence of inflammation in the aqueous or vitreous, and at no time has there been a membrane or snowbank over the pars plana of either eye. He was first examined by us in May 1976, at which time visual acuity was 20/15 in each eye. Media were clear, and fundi, including pars plana, were entirely normal by indirect ophthalmoscopy. With fundus biomicroscopy using a contact lens, there was minimal edema in the macula of each eye, but no cystoid pattern was appreciated. Color photographs of the right and left macula are seen upper left and lower left respectively. Upper center, parafoveal capillaries in the right eye appear normal during early dye transit. Upper right notes subtle but definite leakage from parafoveal capillaries 5 minutes after injection. Lower center, there is parafoveal capillary leakage in left eye 1 minute after injection. Lower right notes cystoid macular edema and late leakage on the optic disc 30 minutes after injection. Since visual acuity was 20/15, we recommended that steroids be discontinued despite the presence of cystoid maculopathy. Comment: This patient demonstrates retinal vascular leakage without other evidence of intraocular inflammation. He has been treated empirically for symptomatic loss of vision in the right eye, but has never experienced nor had recorded visual loss in the left eye. Nonetheless, there is unequivocal angiographic evidence of bilateral retinal vasculopathy in the form of cystoid macular edema. Slide 62. Non-inflammatory occlusive retinal vasculopathy with hemorrhage, Eales disease. This 36-year-old white female presented with a 1-year history of episodic visual loss in both eyes. The systemic steroids prescribed by her referring ophthalmologist had not prevented recurrent retinal and vitreous hemorrhages. A complete systemic and hematologic evaluation at the Johns Hopkins Hospital was non-revealing. She smoked 4 packs of cigarettes a day and drank 10 cups of coffee a day. But cessation of these activities was not followed by any improvement in visual acuity or appearance of the fundi. Visual acuity was 20/50 right eye and 20/16 left eye. Anterior segments were clear. Upper left, note a cotton wool spot with central retinal hemorrhage inferior to the right fovea. Upper center, note that cotton wool spot and hemorrhage obstruct background choroidal fluorescence. Arrow points to occlusion of retinal venule draining inferior macula. Upper right, 5 minutes after injection, note staining of and leakage from terminal branches of the obstructed venule due to hypoxic damage to its endothelium. Lower left, note scattered dot and blot hemorrhages inferior to macular vascular arcade in left eye. Arrow points to obstructed venule, lower left and lower center. In fluorescein angiogram, lower center, note retinal non-perfusion distal to venous obstruction. Lower right, note staining of vessel walls and dye leakage into retina 10 minutes after injection. Comment: this patient demonstrates bilateral retinal venous obstruction with retinal hemorrhages, capillary closure, staining of vessel walls, and leakage from vessels presumably damaged by hypoxia. There was no anterior segment inflammation, and the systemic evaluation was entirely normal. If multiple venous occlusions and capillary non-perfusion progress, she will likely develop secondary retinal neovascularization as a consequence of retinal ischemia. No treatment is recommended at the present time, although some physicians would consider using systemic steroids at this stage. If neovascularization develops, focal and scatter photocoagulation treatment should be considered to reduce the risk of recurrent vitreous hemorrhage. Slide 63. Idiopathic proliferative retinopathy with vitreous hemorrhage. This 17-year-old white male presented with bilateral vitreous hemorrhage. Upper left, note that all fundus details in the right eye are obscured by vitreal blood. Upper center, note stalk of elevated disc neovascularization, left eye. Upper right, note leakage from disc neovascularization, left eye, 30 seconds after dye injection. Center left, note stalk of elevated retinal neovascularization, left eye. Directly center, note dye leakage from stalk of retinal new vessels. Center right, drawing of right fundus after clearing of vitreous hemorrhage shows extensive traction detachment with fibrovascular stalk emanating from disc. Photographs of this fibrovascular stalk are seen lower left and lower center. Lower right, note shrunken fibrotic membrane on right disc following vitrectomy with intraocular cautery of disc neovascularization performed by Dr. Ronald Michaels. Comment: this patient had bilateral proliferative retinopathy of undetermined etiology. A complete systemic evaluation was entirely normal. Glucose tolerance tests and serum protein electrophoresis were normal. Hemoglobin type was AA. Despite technically successful vitrectomy, right eye vision was reduced to hand motion due to severe vascular occlusions. Left eye vision returned to 20/80 after retinal reattachment. The etiology of this occlusive retinal vasculopathy with secondary neovascularization remains obscure, but this may be considered a variety of Eales disease. Slide 64. Occlusive retinal vasculopathy, possibly secondary to contaminated intravenous injection. We have seen two patients with occlusive retinal vasculopathy, secondary neovascularization, and vitreous hemorrhage that may be related to injection of intravenous drugs contaminated by foreign material. This 19-year-old white female injected methadone intravenously. The methadone was drawn into a syringe through non-sterile cotton. 4 days after injection, she developed acute loss of vision in the right eye. Visual acuity was 2200 right eye and 2016 left eye. The left eye was entirely normal. The right eye showed 4+ ray and cells in the anterior chamber and multiple red blood cells in the vitreous. Also noted were multiple vascular occlusions, opacification of vessels with marked venous stasis, and multiple retinal and vitreal hemorrhages. Fundus details at the posterior pole were obscured by diffuse hemorrhage, as seen upper and lower left. Upper center arrows indicate extensive obliteration of retinal vessels and marked perivascular sheathing superotemporal to disc. Lower center note dye staining of and leakage from these vessel walls indicative of hypoxic damage to vascular endothelium. Upper and lower right arrows point to another area of retinal hemorrhage, vascular narrowing, and peripheral capillary closure superior to the disc. Comment: this patient was followed for 6 months with no improvement in visual acuity despite substantial clearing of vitreous hemorrhage. Decreased vision was apparently due to vascular occlusions at the posterior pole. We also saw a patient with Dr. Ronald Michaels who demonstrated multiple retinal vascular occlusions following intravenous narcotic injections. This young man eventually developed a traction and rhegmatogenous retinal detachment, which was successfully repaired by a technique employing vitrectomy and scleral buckling. Presumably, multiple emboli of foreign material produced a diffuse retinal vasculitis that eventuated in multiple vascular occlusions with secondary changes as described. Slide 65. Eales disease following toxoplasmosis. This 32-year-old white male was originally treated by Dr. David Knox for Toxoplasma retinochoroiditis. Some months after resolution of the active infection, he began to experience recurrent vitreous hemorrhages in the right eye. Upper left, arrow indicates area of healed focal retinitis, which now harbors retinal neovascularization. Upper right, arrows point to opacification of retinal vessels temporal to macula. Lower left, supranasal to the disc, note elevated neovascularization and vitreous hemorrhage. Lower right, note vitreal hemorrhage in inferior fundus. Arrows point to sheathed and occluded retinal vessels. Comment: this patient began with toxoplasmosis and eventually developed a picture consistent with Eales disease. He demonstrates peripheral vascular occlusions, secondary neovascularization, and intravitreal hemorrhage. The original infection may be unrelated to the final clinical picture. Because the fluorescein angiogram demonstrated extensive capillary closure throughout the fundus, he was treated with scatter-type argon laser photocoagulation in an attempt to obliterate areas of retinal hypoxia, to promote regression of existing neovascularization, and to reduce the risk of recurrent vitreous hemorrhage. The technique and results of this treatment are seen in the following slide. Slide 66. Photocoagulation treatment for Eales disease with proliferative retinopathy. This 32-year-old white male was described in the previous slide. All photographs are of the superior temporal fundus, right eye. Upper left, adjacent to disc, note intravitreal neovascularization accompanied by fibrous tissue. Upper right, note multiple argon laser burns in photograph taken immediately after photocoagulation treatment. Lesions are scattered, 1 burn diameter apart. Note that no lesions are made directly over the intravitreal neovascularization. Lower left, in a photograph taken 4 months after treatment, note absence of retinal and vitreous hemorrhage and reduction in lumen diameter of intravitreal vessels. Lower right, in photograph taken 1 year following treatment, note further reduction in vascular component of intravitreal proliferative retinopathy. Comment: this patient has maintained 20/20 vision for the past year. He has had 1 minor vitreous hemorrhage from a frond of disc neovascularization, which is not amenable to focal argon laser photocoagulation because of accompanying fibrous tissue. The frequency of the vitreous hemorrhages has been significantly reduced since photocoagulation. The use of scatter argon laser photocoagulation in Eales disease is still considered experimental. It was performed in this case in an effort to reduce the frequency of recurrent vitreal hemorrhages. The rationale for scatter photocoagulation is to obliterate areas of retinal non-perfusion which theoretically elaborate a neovascularization producing substance. In addition to reducing the rate of new vessel formations, this treatment is often followed by regression of disc and retinal neovascularization and thereby reduction in the frequency of vitreous hemorrhages, similar to the sequence of events that follow successful photocoagulation in patients with proliferative diabetic retinopathy. Slide 67. Focal argon laser photocoagulation for proliferative retinopathy in Eales disease. This 42-year-old white male developed blurred vision in the right eye while playing tennis. Examination revealed vitreous hemorrhage in the right eye and several areas of surface retinal neovascularization and peripheral retinal non-perfusion in both eyes. The source of vitreous hemorrhage in the temporal periphery of the right eye could not be determined at the time of initial examination. Upper left is an area of retinal neovascularization in the nasal periphery of the right eye. To prevent vitreous hemorrhage, this area of neovascularization was closed with high-intensity argon laser photocoagulation, upper center. 1 month following treatment, a fluorescein angiogram, upper right, shows no filling of the obliterated neovascularization. 3 months after photocoagulation treatment of the right eye, attention was directed to a small patch of surface neovascularization in the temporal periphery of the left eye, lower left. Note absence of retinal vessels peripheral to this neovascular frond. Capillary closure is appreciated better on the fluorescein angiogram, lower center. 15 minutes after dye injection, lower right, note mark leakage from neovascularization. This small neovascular frond was treated with argon laser photocoagulation as seen in the next slide. Slide 68. Choroidal vitreal neovascularization developing after photocoagulation for retinal neovascularization. This 42-year-old white male with Eales disease was described in slide 67. It was difficult to cause fragmentation in the small frond of neovascularization in the temporal periphery of the left eye, thus necessitating increasing energy and exposure time in an effort to fragment the vessels. A 200 micron beam diameter at 700 milliwatts power and 0.5 seconds duration was used. During treatment, a break in Bruch's membrane was created. This break was then surrounded by intense photocoagulation to prevent further hemorrhage or neovascularization from this area. Upper left is a photograph taken 1 hour after photocoagulation. 1 month later, note photocoagulation scar, upper center. 4 months later, the patient complained of metamorphopsia, although visual acuity was still 20/20. Examination at that time, upper right, showed hemorrhage and intravitreal proliferation from the photocoagulation scar. Fluorescein angiography below shows that the neovascular frond emanates from the choroid and is in fact a choroidal vitreal neovascular membrane. This is shown in the artist's sketch, lower right. Comment: Goldberg and others have previously reported choroidal vitreal neovascularization as a complication of photocoagulation. Their cases occurred following photocoagulation in patients with proliferative sickle retinopathy and proliferative sarcoid retinopathy. In Goldberg's cases, the break in Bruch's membrane was produced either with xenon photocoagulation, utilizing relatively intense energy, or argon laser photocoagulation, utilizing 50 micron beam diameters, while attempting to occlude the feeding arteriole to an intravitreal neovascular frond. Small spot sizes at high energies and short exposure times apparently have the ability to perforate Bruch's membrane, which then sets the stage for subsequent choroidal neovascularization. In this patient, however, no beam diameter smaller than 200 microns was used at any time, and the perforation was made using a 200 micron spot at 0.5 seconds, a fairly long exposure time for argon laser photocoagulation. Thus, it appears that what we consider to be relatively safe treatment parameters, namely larger spot sizes and longer exposures, may also perforate Bruch's membrane. This patient has had recurrent vitreous hemorrhages from this choroidal vitreal neovascular membrane, and no therapy has been possible due to inadequate visualization. Fortunately, the retina has remained attached. When the media clear further, an attempt will be made to close this neovascular membrane. Goldberg has reported only moderate success in closing such membranes utilizing cryotherapy, xenon arc photocoagulation, and partial penetrating diathermy. Slide 69. Retinal angioma with macular detachment and cystoid macular edema. This 39-year-old black male noted poor vision in the left eye while covering the right eye. Right eye vision was 20/16 and was otherwise unremarkable. Left eye vision was 2/200. The media were clear. Upper left, note large red vascular mass at the posterior pole just beneath the fovea. Retinal edema was present throughout the posterior pole, and in some areas there was intraretinal and subretinal lipid deposition as seen upper center. Advanced cystoid maculopathy with lamellar hole formation was evident on fundus contact lens examination. Upper right, artist's sketch shows tumor, retinal edema, and lipid deposition in outer retina and in subsensory retinal space. In fluorescein photographs below, note typical filling pattern of tumor, lower left, and marked dye leakage into retina, lower center, and into vitreous, lower right. Of particular interest in this case was the presence of fine neovascularization on the surface of the tumor. This was appreciated by careful observation of the early frames of the angiogram, as in the photograph lower left. Surface new vessels were also seen when the fluorescein angiogram was examined with a stereo viewer. Tumors without surface new vessels have a relatively smooth edge even late in the angiogram. In this case, we see a diffuse scalloped border throughout the entire fluorescein study. Slide 70. Angioma of the disc. Retinal angiomas may occur anywhere in the fundus, including the disc, as illustrated in the following case. Upper left, note large disc angioma and its accompanying appearance on B-scan ultrasonography. Upper right photograph shows tumor enlarged at 2 times magnification. Lower left, fluorescein angiography shows early filling of tumor. Lower right, in histologic section from another patient, Note multiple dilated capillaries filled with blood, indicating that tumor is a capillary hemangioma. Comment: this patient had good visual acuity and no treatment was recommended. Other investigators have reported significant complications after photocoagulating angiomas on the disc. Slide 71. Multiple angiomas with exudative retinal detachment. This 21-year-old black female had poor vision in the right eye since childhood. Right eye vision was hand motion and left eye vision was 20/16. The right eye had multiple angiomas scattered throughout the fundus, predominantly in the supratemporal and supranasal quadrants. Upper left, note large angioma in far supratemporal periphery. This was associated with an exudative retinal detachment. Upper right, note that dilated feeding and draining vessels can be traced back to the optic disc. Note marked lipid deposition surrounding these dilated vessels. Lower left, note intraretinal and subretinal lipid adjacent to dilated vessels around disc. Lower right, note marked dye leakage from vessels at posterior pole. Comment: management of a patient with retinal angiomas and exudative detachment may require several therapeutic modalities, including xenon arc photocoagulation, transscleral cryotherapy, partial penetrating diathermy, and scleral buckling. Welsh has reviewed the advantages and disadvantages of each of these modalities in his 1971 AOS thesis. Slide 72. Photocoagulation treatment of retinal angioma. This is the left eye of the 21-year-old black female whose right eye was shown in slide 71. Visual acuity was 20/16. Upper left, note isolated retinal angioma with single feeding and draining vessels in supratemporal fundus. Upper center, note that tumor fills rapidly with dye. Upper right, note dye leakage into retina 10 minutes after injection. Center left is a photograph taken immediately following xenon arc photocoagulation. Directly center, note circumscribed chorioretinal scar 3 months after treatment. Repeat fluorescein angiography at this time disclosed patency of vessels in tumor and dye leakage into retina as seen center right. For this reason, additional xenon arc photocoagulation was performed, lower left. 3 months after the second treatment episode, note chorioretinal scar, lower center. Fluorescein angiography now shows no patency of vessels in tumor, lower right. This patient has maintained 20/16's vision and has shown no tumor recurrence for 2 years. Comment: over a period of time, most von Hippel's tumors will grow. Visual impairment may be caused by retinal edema, retinal or vitreous hemorrhage, exudative detachment, and absolute glaucoma. Ideally, tumors should be destroyed prior to the onset of visual impairment. Smaller tumors are more easily obliterated than larger tumors. Tumors less than 1 disc diameter in size may be treated with argon laser or xenon arc photocoagulation. We prefer xenon arc treatment and transscleral cryotherapy for tumors larger than 1 disc diameter in size. Photocoagulation should be applied to the tumor only, not to the feeding or draining vessels. More than 1 treatment episode is usually required. In general, one should treat lightly in order to avoid severe ablatio fugax or exudative detachment, which can occur even after mild treatment. This case illustrates the importance of fluorescein angiography in evaluating the vascular patency of the tumor even after apparently successful closure. Slide 73. Hemoglobin SS and retinal infarction. This 34-year-old black female noted a sudden decrease in vision. Visual acuity left eye was 20/70. Upper left, note loss of foveal reflex and subtle macular edema, left eye. Upper right, note multiple occlusions of macular arterioles surrounding retinal avascular zone, which is at least twice normal size. Arterioles were occluded permanently and visual acuity remained 20/70. Lower left is the inferior fundus of a 29-year-old black female with hemoglobin SS. Dark lesion with white border has been likened to the appearance of a black sunburst. Lower right, 13 seconds after dye injection, hemosiderin-laden macrophages in the center of the lesion obstruct background choroidal fluorescence. Hyperfluorescence along perimeter of lesion corresponds to depigmented area seen on color photograph. Comment: the patient shown above sustained an ischemic infarct in the macula. Goldberg has shown that patients with hemoglobin SS undergo frequent remodeling of the retinal vascular architecture. Prolonged loss of central capillary perfusion, however, usually causes irreversible loss of central vision. The patient shown below sustained a hemorrhagic infarct of the retina. Histopathologically, one might see hemosiderin-laden macrophages in the outer retina and in the subretinal space, in addition to atrophy of sensory retinal elements. Ophthalmoscopically, this appearance has been likened to a black sunburst. Slide 74. Hemorrhagic and ischemic phenomena in hemoglobin SS. Sickling phenomena within retinal capillaries may lead to both hemorrhagic and ischemic infarcts in the retina. When finally resolved, these infarcts may have a variable appearance, and this has led to the use of such descriptive phrases as salmon spots, iridescent spots, and black sunbursts. The final ophthalmoscopic appearance depends in part upon whether the original hemorrhage was located predominantly beneath internal limiting membrane, within retina, or beneath retina. Upper left, note intraretinal and deep retinal hemorrhage in a 44-year-old black male with hemoglobin SS. Upper right photograph, taken 1 year later, shows most of the hemorrhage had reabsorbed, leaving an area of atrophic pigment epithelium and retinal atrophy. Note marked attenuation of retinal arteriole passing through the center of the lesion. Black spicule represents proliferation of pigment from retinal pigment epithelium. Lower left, fluorescein angiography shows capillary closure and obstruction of choroidal fluorescence in this area. Capillary non-perfusion is also seen distal to the lesion. Lower right, in a histopathologic section from another patient with hemoglobin SS, note marked retinal atrophy and pigment proliferation. Slide 75. Hemoglobin SC with proliferative retinopathy. This 21-year-old black male with hemoglobin SC has multiple fibrotic intravitreal C-fans scattered throughout the fundus at the level of the equator. Upper left is a C-fan located in the 6 o'clock position. In addition to considerable fibrous tissue accompanying the vascularized C-fan, arrows point to area of extensive retinal non-perfusion distal to C-fan. Upper right, 17 seconds after dye injection, note first appearance of dye in arteriolar feeding vessel. Identification of the feeding arteriole is important if one wishes to consider photocoagulation treatment. Focal treatment to the frond itself is extremely difficult because of the marked fibrous tissue and because of the intravitreal location. Closure of the C-fan in many instances can be accomplished by obliteration of the feeding arteriole. Lower left, 24 seconds after injection, the C-fan is entirely filled with dye and there is early leakage into the retina. Again, note extensive capillary closure distal to the C-fan. Lower right, in a histopathologic section from another patient, note microscopic features of intravitreal neovascularization. Comment: although the value of photocoagulation treatment has not been documented in a controlled trial to be beneficial in patients with proliferative retinopathy and hemoglobin SC disease, Goldberg has obliterated C-fans in such patients with a low complication rate. He has stated that it is not necessary to treat the frond, but merely to obliterate the feeding arteriolar vessel. This case demonstrates that rapid sequence fluorescein angiography enables the ophthalmic surgeon in most cases to identify this feeder vessel. Slide 76. C-fans with hemoglobin SC. This 19-year-old black male has had 3 vitreous hemorrhages in the left eye. On each occasion, vision returned to 2016. The asymptomatic right eye also had 2016 vision. Upper left, note areas of intravitreal proliferative retinopathy at the equator in the 3 o'clock, 7 o'clock, 9 o'clock, and 12 o'clock positions. Upper center, color photograph shows C-fan in 9 o'clock position. Arrows point to obliterated vessels distal to C-fan. Upper right, note early filling of C-fan 10 seconds after dye injection. Lower left, note complete filling of C-fan during arteriovenous phase. Capillary non-perfusion distal to C-fan is evident. Lower center, 5 minutes after injection, note marked dye leakage into retina and vitreous. Lower right, note marked dye leakage into retina and vitreous from C-fan in the 3 o'clock position. Comment: because the benefits of photocoagulation treatment still require further documentation in patients with proliferative sickle retinopathy, no treatment was recommended in the asymptomatic right eye of this patient. Slide 77. Idiopathic macular hemorrhage. This 36-year-old white female was in good ocular and systemic health when she noted loss of vision in the left eye on awakening. A complete medical and hematologic evaluation were entirely unremarkable. Right eye vision was 20/20 and left eye vision was 20/40. Examination was normal except for a small round hemorrhage in the left macula, upper left. 1 month later, the hemorrhage had resolved entirely, as seen upper right, and vision had returned to 20/20. The fluorescein angiogram shown below shows no abnormality in retinal vessels. Lower left, note macular hemorrhage blocks choroidal fluorescence. 10 minutes after injection, lower right, note absence of dye leakage. This patient has been followed without recurrence for 2 years. Comment: macular hemorrhage is ordinarily a sign of significant vascular disease, but may appear in otherwise healthy individuals without apparent cause. Systematic ocular and systemic evaluation in such patients may fail to reveal any etiology. A patient may notice sudden loss of vision in one eye following a severe spasm of coughing. In such instances, macular hemorrhage may be related to a Valsalva maneuver with the same pathogenesis as a subconjunctival hemorrhage that often follows a coughing spasm. Slide 78. Acute hypertensive retinopathy. This 21-year-old black female complained of blurred vision in both eyes. Visual acuity was 20/25. Blood pressure was 200/120. Upper left, note multiple peripapillary cotton wool spots. Upper center, 7 seconds after dye injection, nerve fiber layer edema partially obstructs fluorescence in superior temporal branch artery. Upper right, 11 seconds after injection, early leakage from terminal arterioles is caused by hypoxic damage to vascular endothelium. Areas of capillary closure are indicated by arrows. Lower left, 42 seconds after injection, note continued leakage from ischemic retinal vessels. Lower center, note similar changes in peripapillary region of right eye. Retinal capillary non-perfusion produces a microinfarct in the nerve fiber layer, which appears as a cotton wool spot clinically and a cytoid body histologically. Edema in the anterior retinal layers obstructs background choroidal fluorescence. By interfering with the passage of blue wavelengths from camera to choroid and with the transmission of yellow-green wavelengths from choroid to camera. This is illustrated in the artist's sketch, lower right. Comment: the cotton wool spots or nerve fiber layer microinfarcts seen in hypertensive retinopathy may fade or disappear completely over a period of months. When fluorescein studies are repeated in such instances, the non-perfused segments are seen to be perfused again. Treatment should be directed towards reducing the systemic blood pressure. Slide 79. Lupus erythematosus with hypertensive retinopathy. This 24-year-old white female with systemic lupus erythematosus complained of poor vision in both eyes. Acuity was 2200 OU. Both fundi showed multiple cotton wool spots at the posterior pole and marked retinal non-perfusion throughout the fundus. Upper left, red-free photograph shows multiple cotton wool spots in right macula. Upper center, note marked capillary non-perfusion in areas corresponding to cotton wool spots. Upper right, reduced flow through arterioles has caused hypoxic damage to vascular endothelium, resulting in dye staining of vessel walls and dye leakage into retina. Center left, note cotton wool spots beneath right disc. Lower left, hypoxic damage to the vascular endothelium in same area results in staining of vessel walls and dye leakage into retina. Directly center, in photograph of left disc taken in red-free light, and lower center, in fluorescein angiogram of left disc, note dye staining of vessel walls. Note similar findings center right in superotemporal region of left eye and lower right in fluorescein angiogram of same region. Comment. Severe hypertension, irrespective of etiology, results in arteriolar narrowing, capillary closure, nerve fiber layer infarcts, and poor visual acuity when the macula is involved. The only therapy of benefit is reduction of systemic blood pressure. Since systemic hypertension is frequently associated with renal involvement, careful evaluation of the renal status is also advisable. Slide 80. Retinal arterial macroaneurysms. Retinal arterial macroaneurysms are acquired abnormalities usually seen in older patients. Coexistent medical problems, particularly hypertension, are found in more than half of the patients demonstrating this unusual ophthalmoscopic abnormality. When visual acuity loss occurs, it may be due to macular hemorrhage, macular exudate, or occasionally vitreous hemorrhage. This 70-year-old white female noted gradual decrease in vision in the right eye. Upper left, note hemorrhagic lesion surrounded by lipid ring. Also note marked hyalinization of branch retinal arteriole passing through center of lesion. Two small nodular lesions are seen beneath superficial hemorrhage. Upper right, 15 seconds after fluorescein injection, macroaneurysms are filled. Arrow points to areas of focal constriction in branch retinal arteriole, proximal and distal to macroaneurysms. Lower left, 30 minutes after injection, note dye leakage into retina. Lower right, subtle but definite dye leakage in the macula explains visual loss. Comment. Query reported the natural history and visual prognosis in 19 patients with retinal arterial macroaneurysms. 12 of 19 patients presented with macular hemorrhage. In 7 of these 12 patients with macular hemorrhage, vision returned to normal in 6 to 8 weeks when the blood reabsorbed. 5 of the 12 patients had incomplete visual recovery for the following reasons: vitreous hemorrhage, preretinal fibrosis, macular artery occlusion, and pigment epithelial atrophy in the fovea. 6 of 19 patients presented with macular edema. The best final visual acuity in all 6 was 20/80. Reasons for visual loss were persistent macular edema in 5 patients and coexistent macular branch vein occlusion in 1 patient. Some patients may benefit from photocoagulation treatment, as illustrated in the next slide. Slide 81. Photocoagulation treatment of retinal arterial macroaneurysms. This 70-year-old female was illustrated in slide 80. Upper left, note marked lipid deposition in the macula prior to photocoagulation treatment. Visual acuity was 2200. Upper right is a photograph taken immediately following argon laser photocoagulation treatment. Lesions of moderate intensity utilizing a beam diameter of 200 microns were delivered to the macroaneurysms. Lower left is a photograph of the macula 4 years after photocoagulation, at which time visual acuity was 20/20. Lower right is a photograph of the photocoagulation scar. The patient has been asymptomatic for 4 years. Comment: this case illustrates that selected patients with macular edema secondary to leakage from retinal arterial macroaneurysms may benefit from careful photocoagulation treatment. We do not advocate routine treatment of macroaneurysms unless macular edema and exudates cause at least 2 lines reduction in visual acuity. This conservative approach is recommended since some investigators have observed major retinal hemorrhage following photocoagulation therapy to the macroaneurysms. Slide 82. Cavernous hemangioma of the optic disc. Cavernous hemangioma of the optic disc and retina is a rare congenital abnormality. Except in the unusual circumstance of macular hemorrhage or vitreous hemorrhage, visual acuity is usually not affected. Typically, aneurysms appearing like clusters of grapes are seen on the surface of the optic disc or in the superficial retina. There may be hemorrhage within the walls of these aneurysms or surrounding them, as seen in the photograph upper left. Upper right, smaller aneurysms are more apparent in red-free light. Circulation within these aneurysms is extraordinarily slow, and filling is often delayed until the mid to late venous phase. Lower left, 26 seconds after injection, is the first appearance of dye in aneurysms. Ordinarily, there is no significant dye leakage into retina or vitreous, although dye may persist within the aneurysm itself 1 hour or more after injection, as seen lower right. Note the plasma erythrocyte separation within aneurysm. Dye fills upper half of aneurysm only, since bottom half is filled with red blood cells. Comment: this lesion was discovered in a 55-year-old white female on routine ophthalmoscopy 10 years ago. A slightly enlarged blind spot was the only positive finding other than on ophthalmoscopy. It is of interest that she has had several episodes of spontaneous ecchymosis into the right lower lid. Since a number of patients with cavernous hemangioma of the optic disc and retina have associated vascular abnormalities in the skin or brain, the spontaneous ecchymosis in this patient may reflect bleeding from a vascular malformation in the orbit. Angiomatous lesions in the retina cause visual disability only rarely, so that no treatment is recommended. It is interesting to follow the lesions with serial photographs. Slide 83. Macroglobulinemia. This 62-year-old white female with macroglobulinemia and hyperviscosity syndrome complained of fatigue and gastrointestinal bleeding. Her systemic disease responded to intravenous Cytoxan. She also complained of blurred vision in the left eye. Visual acuity was 20/15 right eye and 20/40 left eye. The media were clear. The right eye was normal. Upper left, note dilated tortuous veins and multiple superficial and deep hemorrhages in the left macula. Upper center, note early dilatation of perifoveal capillaries 20 seconds after dye injection. Upper right, note early cystoid macular edema 15 minutes after injection. As the systemic disease improved in response to treatment with intravenous Cytoxan, the fundus picture also cleared. Lower left, note partial resolution of hemorrhages in the left macula 2 months later. Despite resolution of hemorrhages, cystoid maculopathy still persists, as seen lower center. 1 year later, lower right, cystoid changes are less apparent and visual acuity has improved. Comment: dysproteinemic states produce fundus abnormalities because of hyperviscosity, which impairs flow in the retinal microcirculation. Reduced rate of flow causes hypoxic damage to the vascular endothelium and incompetence of capillaries. As viscosity is reduced by systemic treatment, the entire clinical picture may improve as indicated in this patient. In addition to abnormalities in retinal vessels, sludging may also be visible in conjunctival vessels. Slide 84, choroidal hemangioma. This 42-year-old white male noted blurred vision in the right eye. Visual acuity was 20/20 OU. The left eye was entirely normal. The right eye had a choroidal thickening inferotemporal to the disc, 4 disc diameters in size, with about 1.5 millimeters elevation. Subretinal fluid was visible at the margins of the lesion. Upper left is a color photograph of the lesion, and upper center is a photograph taken in red-free light. Upper right, 7 seconds after dye injection, note early filling of the lesion from the choroidal circulation before any dye has entered the retinal circulation. Lower left, 14 seconds after fluorescein injection and 7 seconds after appearance of dye in the choroidal lesion, note first appearance of dye. Lower left, 14 seconds after fluorescein injection and 7 seconds after appearance of dye in the choroidal lesion, note first appearance of dye in the retinal circulation. Lower center, 21 seconds after injection, retinal circulation is now completely filled and there is beginning dye leakage from the choroidal lesion. Lower right, 1 hour following dye injection, note complete absence of dye from retinal circulation, but leakage of dye from the choroidal lesion into the subretinal space and retina. Comment: there is no fluorescein angiographic appearance absolutely typical of either choroidal hemangioma or melanoma. Very early filling of a lesion is suggestive of choroidal hemangioma, but this pattern may also occur with choroidal melanoma. The lack of pigmentation does not rule out the possibility of melanoma, since amelanotic melanomas are well described. This patient was seen through the courtesy of the oncology unit of the retina service at Wills Eye Hospital. Diagnostic studies performed there included a negative P32 test and a B-scan ultrasonogram, which showed an oval-shaped echo with a smooth anterior border, numerous internal reflections, and no choroidal excavation. Both tests were consistent with the diagnosis of choroidal hemangioma rather than melanoma. It is of interest that this patient did not show cystoid retinal edema overlying the presumed hemangioma, a finding often seen with long-standing hemangiomas. No treatment was recommended other than periodic follow-up. Should visual acuity diminish because of macular edema, photocoagulation of mild to moderate intensity overlying the lesion would be indicated. Slide 85. Racemose arteriovenous aneurysm of disc and retina. Racemose arteriovenous aneurysm of disc and retina is a rare congenital abnormality. Visual acuity is usually not affected unless the macula is involved. In any event, visual stability is the rule, even though there may be visual loss at the time the patient is first seen. The changes are most often confined to one eye, although bilateral involvement has been reported. Upper left and lower left note large dilated arteries and veins on the disc and in the macular region. Upper and lower right, dye fills large vessels, but there is no leakage into retina. Photographs taken 30 minutes after injection also fail to show any evidence of leakage, indicating competency of the retinal capillaries. Comment: racemose aneurysms are ophthalmic curiosities. No treatment is recommended. Wyburn Mason observed many years ago that some patients have associated intracranial arteriovenous abnormalities. Although we do not recommend routine cerebral angiography in asymptomatic patients, the ophthalmologist should be alert to the possible coexistence of intracranial and retinal arteriovenous malformations so that neurologic consultation may be obtained in patients with neurologic symptoms. Slide 86. Racemose arteriovenous aneurysm of disc and external ocular structures. This 42-year-old white female has had numerous hythemas in the left eye for which no apparent cause has been found. After clearing of blood from the anterior chamber, visual acuity has always returned to 20/20. The right eye was not affected. Upper left, note arteriovenous malformation of the left disc. The vascular loop extends about 1 disc diameter into the vitreous cavity. Upper right, AV malformation is filled with dye but does not leak. Photographs taken 30 minutes after injection also showed no leakage of fluorescein. Lower left and lower right, note arteriovenous malformations over caruncle and over lateral canthal area, respectively. No hemorrhages have been observed in these areas. Comment. This patient illustrates that congenital arteriovenous malformation of the retina may be associated with similar vascular malformations elsewhere in the eye. Presumably, recurrent hythemas in the left eye were due to vascular malformations of the iris. Careful slit lamp and gonioscopic examination, however, revealed no vascular abnormalities. Iris angiography may have revealed subtle vascular abnormalities of the iris, but this technique was not available at the time this patient was examined. Slide 87. Sarcoid retinopathy. This 21-year-old black female complained of poor vision in both eyes for 3 months. Right eye vision was 3/200 with marked anterior segment and vitreous inflammation. The fundus could not be visualized. Left eye vision was 20/50. Upper left, note choroidal infiltrate in macula. Upper center, arrows point to early staining of choroidal lesion. Upper right, note dye leakage into retina 30 minutes after injection. The patient was treated with topical and systemic steroids. 1 month later, center left, note progression of choroidal infiltrate in macula. 2 months later, directly center, note beginning resolution of choroidal infiltrate. 15 months later, center right, note complete resolution of choroidal infiltrate with macular scarring. Visual acuity was still 20/50. Lower left, superotemporal to macula are 2 additional areas of active choroidal inflammation with surrounding retinal edema. Lower center, note dye leakage into retina from areas of active inflammation. Lower right, 15 months later, note resolution of choroidal infiltrates and reabsorption of retinal edema. Comment. Ocular lesions occur in 25 to 65% of patients with sarcoidosis. The frequency of fundus lesions is difficult to ascertain because anterior segment and vitreous inflammation often precludes careful fundus examination, as in the right eye of this patient. Fundus manifestations include chorioretinitis, periphlebitis, choroidal granulomas, optic nerve involvement, and peripheral retinal neovascularization secondary to retinal non-perfusion. Fundus involvement in sarcoid may be a clue to the presence of intracranial involvement, whereas only 2% of all patients with sarcoid show evidence of central nervous system disease. Among the patients with fundus involvement, 37% were reported to have intracranial involvement. This patient did not have evidence of central nervous system disease. Involvement of the posterior segment, either through optic nerve disease, vitreous inflammation, choroidal infiltration, or periphlebitis, may cause decreased visual acuity and may be an indication for treatment with systemic steroids. The fundus lesions in this patient responded to treatment with prednisone. Slide 88. Sarcoidosis with periphlebitis and peripheral retinal neovascularization. This 47-year-old black male had sarcoidosis proved by lymph node biopsy. Blood pressure was normal and hemoglobin type was AA. Upper left, note venous dilatation and arteriovenous nicking inferior to the right disc. Upper center, note retinal hemorrhage and cotton wool spots in same area 3 months later. Upper right, 1 year later, note marked periphlebitis and extensive retinal hemorrhage. Lower left, large arrow points to peripheral neovascularization in nasal periphery of left eye. Small arrows indicate obliterated retinal arteriole distal to neovascularization. Lower center, note filling of neovascularization 20 seconds after dye injection. Capillary closure is seen distal to neovascularization. Lower right, note marked dye leakage into retina and vitreous 10 minutes after injection. Comment: this case demonstrates that in patients with sarcoidosis, vascular inflammation may lead to obliterative changes. When retinal non-perfusion is extensive, secondary neovascularization may develop, as in other proliferative retinopathies. In an effort to prevent vitreous hemorrhage, patients with sarcoid and retinal neovascularization may be candidates for photocoagulation treatment. Slide 89. Retinitis pigmentosa with cystoid macular edema. This 42-year-old white male has been night blind since age 17. For the past 3 years, he has noted progressive loss of central vision as well. Visual acuity was 20/40 in each eye. Upper left, note cystoid space in right macula, extensive pigment loss surrounding macula, and pigment migration into the retina above inferotemporal vessels. Lower left, note cystoid macular edema 30 minutes after dye injection. Upper center, note temporal disc pallor and subtle cystoid changes in macula of left eye. Lower center, cystoid maculopathy is readily appreciated on fluorescein angiogram 15 minutes after injection. Upper right, note extensive pigment migration into retina in bone spicule pattern. Lower right, note ring scotoma, right eye. Comment: retinitis pigmentosa is an inherited retinal dystrophy characterized by the following findings: early night blindness, early loss of mid-peripheral visual field, preservation of central visual acuity until relatively late in the course of the disease, attenuation of retinal vessels, and pigment migration into the retina in a bone spicule pattern beginning at the equator. Recently, cystoid macular edema has been described in patients with retinitis pigmentosa. Cystoid maculopathy results from perifoveal capillary leakage with fluid accumulating in the Henle fiber layer of the macula. No treatment is known. Slide 90. Normal iris angiogram. Before proceeding to a study of abnormal conditions, it is useful to review the appearance of the normal iris and the normal iris angiogram. Upper left is iris of a normal 26-year-old white female. Upper center, 16 seconds after dye injection, note filling of conjunctival vessels with no visible dye in iris vessels. Upper right at 18 seconds, note early filling of iris vessels. Lower left at 28 seconds, note complete filling of iris vessels with no leakage into iris stroma. Lower center, 1 minute after injection, most iris vessels remain filled with no evidence of leakage. Lower right, 10 minutes after injection, many iris vessels are still visible, but no dye leakage is present. Slide 91. Pigmented iris lesion. This 21-year-old white female has been followed for 1 year with a pigmented iris lesion. Visual acuity was 20/20. Upper left, note a fleshy pigmented lesion in the 7 o'clock position with a vessel in the center of the lesion. Note how the pupil dilates unevenly adjacent to this lesion. Upper center, upper right, lower left, and lower center are rapid sequence iris angiograms taken over a 3-second period. Upper center and upper right, note filling of vessel in pigmented lesion prior to appearance of dye in normal iris vessels. Lower left and lower center, note early dye leakage from iris vessels in lesion. Lower right, 15 minutes after injection, note marked dye leakage into iris stroma. Comment: since this lesion has not grown and does not involve the structures of the anterior chamber angle, it is being managed conservatively. We do not believe that P32 studies are warranted, for they pose an unnecessary risk to the patient. Fluorescein photographs are useful in this case in demonstrating the prominence of abnormal vessels within the lesion. Slide 92. Presumed iris melanoma. This 44-year-old white male noted a pigmented lesion of the right eye while shaving. Visual acuity was 20/16. Upper left, note a fleshy lesion between 6 and 9 o'clock with ectropion uvei in the 8 o'clock position. In the gonio photograph upper right, note that lesion does not extend to anterior chamber angle. Lower left, 30 seconds after dye injection, note fluorescence from abnormal vessels which were not visible by slit lamp examination. Lower right, 15 minutes after injection, note dye leakage from vessels in tumor and absence of leakage from iris vessels away from tumor. Comment: this patient has been followed with serial photographs at 6-month intervals for the past 4 years and has demonstrated no growth of the lesion. Unless growth is documented by photography or unless involvement of the angle occurs, treatment will be deferred. Although the lesion is presumed to be a melanoma, Dr. Angus McLean commented to us that the lesion resembles a leiomyoma of the iris, which he excised and verified histopathologically many years ago. Slide 93. Pathogenesis of rubeosus iridis in diabetes. We have seen that patients with proliferative diabetic retinopathy invariably have evidence of widespread retinal non-perfusion when studied with fluorescein angiography. Some of these patients develop rubeosus iridis. The pathogenesis of rubeosus may be similar to the pathogenesis of the proliferative retinopathy in that capillary closure seems to play an important role. In fact, it is unusual to see a diabetic patient with rubeosus who does not have proliferative retinopathy as well. This 57-year-old white female has had diabetes for many years and has been followed by us since 1970. Upper left is a 1971 photograph of the right disc showing scattered hemorrhages and no proliferative retinopathy. Upper right is a 1975 photograph taken several days after a vitreous hemorrhage which obscured fundus details. Despite vitreous blood, one can see a venous loop nasal to the disc and a suggestion of disc neovascularization as well. Lower left, note disc new vessels in a photograph taken 2 months later when vitreous hemorrhage had cleared. At the same time, lower right, note peripupillary rubeosus iridis. Less well seen are the new vessels along the temporal perimeter of the iris. On gonioscopy, vessels were seen to cross the anterior chamber angle. Management of this case will be discussed in the next slide. Slide 94. Management of iris neovascularization by retinal scatter photocoagulation. This 57-year-old white female developed proliferative retinopathy and rubeosus iridis in the right eye after being observed with background retinopathy only for 5 years. Upper left, note disc neovascularization. Lower left, note complete regression of disc neovascularization and marked attenuation of venous loop nasal to disc 1 month following scatter argon laser photocoagulation. Iris angiography before photocoagulation is shown above and 2 weeks after photocoagulation below. Upper center, 22 seconds after dye injection, note marked peripupillary rubeosus and new vessels along temporal perimeter of iris. Upper right, 4 minutes after injection, note marked dye leakage into iris stroma. Post-photocoagulation iris angiogram is shown below. Lower center, 22 seconds after injection, note marked diminution of peripupillary rubeosus when compared to the pre-photocoagulation angiogram above. Also note complete regression of new vessels along the temporal iris border. Lower right, 4 minutes after injection, Note persistent leakage from iris new vessels in the peripupillary region. Amount of leakage is definitely diminished, however, when compared to the pretreatment angiogram above. Comment: the prevalence of rubeosis in patients with diabetic retinopathy far exceeds the prevalence of neovascular glaucoma, and these terms should not be confused. Indeed, a number of patients have been followed with small tufts of iris new vessels, particularly in the peripupillary region, and no evidence of vascular invasion of the anterior chamber angle. Intraocular pressure is usually normal when rubeosis is confined to the peripupillary area. We have had promising results in a limited number of patients using scatter argon laser photocoagulation for rubeosis. Our hypothesis is that retinal ischemia is responsible for elaboration of a neovascularization producing substance which stimulates growth of new vessels on the iris as well as in the retina. Obliteration of areas of retinal hypoxia may reduce availability of this substance. This is followed in many instances by partial or complete regression of iris neovascularization. In this patient, scatter photocoagulation promoted regression of disc neovascularization as well as iris neovascularization. Visual acuity remains 20/25. You have now completed a preliminary course on fluorescein angiography and retinal vascular disorders. The next 6 slides will test your progress thus far. A brief clinical history will be given for each slide. Then you will be asked several questions. Please write down your answers to the questions. After slide 100, return to slide 95 for a discussion of the 6 cases. If you missed any, you may wish to refer to the appropriate section in the course. Slide 95, quiz slide number 1. This 57-year-old white male noted loss of vision in the left eye. Visual acuity was 20/20 right eye and 20/50 left eye. The left eye had a dense superior altitudinal hemianopia. Upper left is a color photograph of the left macula, and upper center is a photograph of the left disc taken with red-free light. Upper right is a photograph 18 seconds after dye injection, lower left 30 seconds after injection, lower center 5 minutes after injection, lower right 30 minutes after injection. Here are your questions. 1. What is the diagnosis? 2. What is the etiology? 3. If you saw this patient acutely, what therapeutic maneuvers would you employ? 4. How should this patient be evaluated from a diagnostic point of view? Slide 96, quiz slide number 2. This 54-year-old white male noted sudden loss of vision in the right eye. Visual acuity was 20/40. Here are your questions. 1. What is the diagnosis? 2. With what systemic and ocular conditions is this disorder associated? 3. Describe the angiographic findings. 4. Is there any treatment documented to be of benefit for this condition? Slide 97. Quiz slide number 3. This 58-year-old white male complained of metamorphopsia in both eyes. Despite symptoms, visual acuity could be corrected to 20/16 in each eye. The left macula is seen in the upper 3 photographs. Lower left is a fluorescein photograph superior to the left disc. Lower center and lower right are photographs of the right macula. Here are your questions. 1. What is the diagnosis? 2. What are the indications for photocoagulation in this disorder? 3. Would you recommend photocoagulation for this patient now? If so, why? If not, why not? Slide 98. Quiz slide number 4. This 40-year-old white female has noted blurred vision in both eyes for several months. She has no systemic disease. Visual acuity was 20/20 right eye and 20/40 left eye. The anterior segments were unremarkable, but there were vitreous cells bilaterally. The right fundus was normal by direct ophthalmoscopy. Upper left is a photograph of the left macula. Fluorescein photographs of the left macula are seen as follows. Upper center, 12 seconds after dye injection. Upper right, 26 seconds after injection. Lower left, 5 minutes after injection. And lower center, 20 minutes after injection. Lower right is a photograph of the right macula 20 minutes after injection. Here are your questions. 1. What is the morphologic diagnosis visible on the fluorescein studies? 2. Name 4 conditions commonly associated with this morphologic entity. 3. What do you consider to be the likely diagnosis in this case? 4. What other ophthalmoscopic findings might one see in this patient utilizing indirect ophthalmoscopy? 5. What treatment is recommended for this disorder? Slide 99, quiz slide number 5. This 25-year-old white male recently noticed reduced vision in the right eye. He is somewhat obese but has no systemic disease. Upper left is a color photograph of the right macula. The upper right photograph is taken in red-free light and oriented slightly temporal to the upper left photograph. Below are fluorescein photographs taken 10 seconds after injection lower left and 20 minutes after injection lower right. Here are your questions. 1. What is the morphologic diagnosis? 2. What diagnostic steps are indicated to establish a possible relationship to systemic disease? 3. Do you consider this entity amenable to treatment? If so, describe indications. Slide 100, quiz slide number 6. This 21-year-old black male has had recurrent vitreous hemorrhage in the right eye. Upper left is a representative area of the temporal fundus right eye. Upper right is a photograph of the same area taken in red-free light. Lower left photograph is taken 10 seconds after dye injection, and lower right photograph is taken 49 seconds after injection. Here are your questions. 1. Describe the morphologic features on the fluorescein angiogram. 2. What diagnoses ought to be considered? 3. What studies would you request to establish the diagnosis? 4. How would you manage this patient? Now return to slide 95 and we will review the findings and answer the questions. Slide 95. Answer to quiz slide number 1. The patient has an acute inferior papillary branch artery occlusion. Retinal whitening is due to intracellular edema of the inner retinal layers that follows acute arterial occlusion. Upper center, note the white embolus that obstructs the inferior papillary branch artery in center of disc. Upper right and lower left, note that the inferotemporal branch artery does not fill with dye. Lower center, 5 minutes after injection, note retrograde filling of obstructed branch artery. Lower right, 30 minutes later, note dye stains the wall of obstructed vessel. Regarding therapy, if one were to see this patient acutely, one might consider vigorous massage of the globe in an effort to propel the embolus downstream into a more peripheral branch artery, thereby attempting to reestablish the posterior pole circulation. Massage also has the effect of reducing intraocular pressure, thereby lowering resistance to arterial inflow. Carbonic anhydrase inhibitors administered by mouth or IV can augment the lowering of intraocular pressure. Retinal arterial emboli may arise from the bifurcation of the ipsilateral internal carotid artery, from mural thrombi in the left atrium, particularly in patients with cardiac arrhythmia, from an atrial myxoma, or even from deep leg veins in patients with thrombophlebitis and atrioventricular septal defects. Patients with embolic occlusion of retinal arteries should have thorough cardiac and neurologic evaluation. Ultrasonography of the heart is a useful, non-invasive technique for ruling out the possibility of atrial myxoma. Slide 96. Answer to quiz slide number 2. This patient has obstruction of the superior temporal branch vein. Upper left, arrow points to obstruction site where second-order branch arteriole crosses first-order branch venule. Note nerve fiber layer hemorrhages and cotton wool spots in macula. Upper right, 14 seconds after dye injection, arrow indicates site of obstruction. Note absence of laminar flow in venule distal to obstruction site, while laminar flow is seen clearly in venule proximal to site of obstruction. Lower left, 20 seconds after injection, arrow points to dilated capillaries shunting blood across horizontal raphe to circumvent obstructed vein. Lower right, 20 minutes after injection, note extensive leakage from dilated capillaries and well-developed cystoid maculopathy. Approximately 75% of patients with branch retinal vein obstruction have elevated blood pressure, and approximately 15% of patients with branch retinal vein occlusion have ocular hypertension or glaucoma. No treatment has been documented to be of benefit in a prospective controlled study. A randomized clinical trial evaluating the effect of argon laser photocoagulation for patients with branch retinal vein occlusion and macular edema is now in progress at the Wilmer Institute. Slide 97. Answer to quiz slide number 3. This patient has background diabetic retinopathy in both eyes. Metamorphopsia can be explained on the basis of bilateral macular edema. Note microaneurysms and hard exudate in the left macula, upper left. Note areas of hyperfluorescence 30 seconds after dye injection, upper center. 30 minutes after injection, upper right, note dye leakage into retina. Lower left, note vascular abnormalities and areas of capillary closure above left disc. The right macula, lower center and lower right, shows less severe vascular changes than the left macula. Prospective randomized trials at the Wilmer Institute and in a cooperative trial in London showed that photocoagulation is effective for certain patients with diabetic macular edema. In the Wilmer study, approximately 25% of treated eyes had visual improvement of 2 lines or more following photocoagulation. Many treated eyes experienced stabilization of visual acuity when compared to untreated eyes with similar degrees of retinopathy and similar initial visual acuities. We do not recommend photocoagulation for this patient since he has only metamorphopsia and vision is 20/16 in each eye. Kohner showed that microaneurysms have a definite half-life, and it is entirely possible that the microaneurysms visible today will no longer be present 6 months from now. Thus, this patient may maintain good visual acuity for some time without photocoagulation. He should be followed at regular intervals and would be considered a candidate for photocoagulation treatment should visual acuity deteriorate in either eye. He would be a candidate for scatter photocoagulation if he develops disc neovascularization or retinal neovascularization with vitreous hemorrhage in either eye. Slide 98. Answer to quiz slide number 4. This patient demonstrates classical cystoid macular edema in the left eye and subtle but definite cystoid edema in the right macula, as seen lower right. The following conditions are frequently associated with cystoid macular edema. 1. Aphakia. 2. Diabetic retinopathy. 3. Branch retinal vein occlusion. 4. Intraocular inflammation. There are at least 40 other conditions associated with cystoid macular edema, including retinitis pigmentosa, nicotinic acid ingestion, retinal detachment surgery, subretinal neovascularization, pre-retinal macular fibrosis, etc. With bilateral cystoid maculopathy and bilateral vitreous cells, one must consider an inflammatory disorder. Utilizing the indirect ophthalmoscope, a white membrane was seen over the inferior pars plana in the left eye. The diagnosis in this case is pars planitis syndrome, etiology unknown. Although no treatment has been documented to be of value in a prospective randomized clinical trial, we have used systemic steroids, usually 60 to 80 milligrams daily, to manage patients with active vitreal inflammation and cystoid macular edema. If there is no documented improvement in visual acuity after 7 to 10 days, we discontinue steroids. If visual acuity does improve on this regimen, We reduce steroids to the lowest possible dosage, which maintains good visual acuity. When significant systemic side effects of steroid therapy develop, we may employ subtenon's injection. Slide 99. Answer to quiz slide number 5. The morphologic diagnosis is circinate retinopathy. In all cases of circinate retinopathy, irrespective of etiology, there are dilated vascular segments in or near the center of the lipid ring. The entire area inside the lipid ring is edematous. As one gets farther from the leaking vessels, however, the transudate is reabsorbed, leaving lipid and lipoproteins often engulfed by macrophages in a ring surrounding the vascular abnormalities. The first diagnostic possibility is diabetic retinopathy, but this patient had a normal glucose tolerance test. Lipoprotein electrophoresis was also normal. Branch retinal vein occlusion may occasionally produce a picture like this, but there is no evidence of venous obstruction in this patient. In addition, the vascular abnormalities are not confined to the distribution of a single venule, as is the usual case with branch vein obstruction. The dilated vascular segments visible on the fluorescein angiogram lower left are rather typical of what one sees in retinal telangiectasis, or what some have called a variety of Coats disease. Patients with circinate retinopathy are candidates for photocoagulation treatment when the lipid and or edema encroaches on the central fovea. Photocoagulation of abnormal vascular segments in the center of the lipid ring may be followed by reabsorption of lipid and edema and improvement in vision after several months. This patient was treated with photocoagulation, and 6 months later, vision improved from 20/50 to 20/30. Additional photocoagulation was performed at that time to obliterate the remaining leaking vessels, and visual acuity subsequently improved to 20/25, where it has remained for 1 year. Slide 100. Answer to quiz slide number 6. This patient has intravitreal fibrovascular proliferation in the mid-periphery of the retina. Lower left, note that neovascularization grows at the interface of perfused and non-perfused retina. In photographs above, arrows indicate absence of vessels distal to neovascularization. Lower right, note dye leakage from intravitreal new vessels and retinal non-perfusion distal to neovascularization. Intravitreal proliferative retinopathy occurs commonly in diabetes, RLF, and sickle cell hemoglobinopathy. This patient had a normal glucose tolerance test and hemoglobin type SC. Photocoagulation has not been proved to be of benefit in patients with hemoglobin SC proliferative retinopathy. On the other hand, closure of C-fans prior to vitreous hemorrhage may preserve vision in some patients. Rapid sequence angiography assists in identifying the feeding arteriole to the intravitreal frond or C-fan. Focal argon laser treatment may be used to close the feeder. Subsequently, the C-fan may regress, thereby reducing the risk of vitreous hemorrhage. The self-evaluation quiz was provided to assess your knowledge of the diagnosis and management of retinal vascular disorders, including fluorescein angiography interpretation. You may use other slides in this series in a similar self-evaluation by making your diagnosis before listening to or reading the descriptive material. We hope that you have enjoyed this course and that you will continue to find it useful